नहीं वही लिंक सेम लिंक।
हमारे 500 रुपए किसान
सेम लिंक किया ना।
अभी ये तो शुरू हो गया।
आवाज यहाँ से आ रहा है, म्यूट कर।
Public Health, Hyderabad, in collaboration with the Oklahoma State University, USA. It is a pleasure to see so many of you here today, united by a shared commitment to exploring and addressing the critical intersections of human, animal, and environmental health. I first of all welcome everyone, especially the guests of honor and the distinguished guests here for the traditional lighting of the lamp. Welcome you to the stage, please. Our guests, especially Sri Narendra ji, Dr. Anil Paul, Dr. Akhilesh, Dr. Ekambaram, Dr. Yogeshwari, and Professor Jerry Malagar. Thank you. I request the other panel members also who are here to please join for the traditional lighting of the lamp. Please, Dr. Nandu and the others. Sushma. Sir, please. Raman sir. Excellent. Thank you very much for that fantastic start. Now I invite our guest of honor for today's program, Sri Dr. G. Narendra Kumar, IAS, Director General, National Institute of Rural Development in Panchayati Raj, to kindly give the inaugural address. And I will introduce Sir Dr. G. Narendra Kumar, IAS, AGMUT 1989, has assumed charge as Director General of National Institute of Rural Development and Panchayati Raj at Rajendra Nagar, Hyderabad on 27 January 2021 for a period of 5 years. Earlier, he was the Additional Chief Secretary, Government of Delhi. Dr. Narendra Kumar ji, IAS, possesses a PhD from Osmania University and holds a master's degree in public administration from the Maxwell School of Public Affairs, USA, and a certificate course in the information system management from Syracuse University in the US. He was instrumental in setting up of 4 universities in Delhi, as well as in increasing access to quality technical and higher education in Delhi. Dr. Narendra Kumar ji is also known for developing Pondicherry as the hardware capital of India. He was also the IT secretary in the Government of India. Earlier, he also worked in various national and international academic institutions such as ASCII, which is the Administrative Staff College of India, as well as ICRISAT. Besides his wide range of administrative experience in environmental protection, social and sustainable development. So I kindly invite our guest, Shri G. Dr. Narendra Kumar, IAS, Director General, NIR, DPR, to the stage to give the inaugural address. And I request Professor Paul to give him a planter.
Professor Anil Kaur, distinguished delegates and esteemed participants, it's my great pleasure to participate in the symposium on One Health. I've been given 5 minutes to speak on this, so I've come prepared only with 5 points that I will make, 5 short points. On One Health, importance of One Health, all of you know better than I would know. One Health, as you all know, has become prominent with the pandemic, with COVID. It's been there around, as all of us know, but it has really come into prominence with the COVID, and therefore we need to leverage on that to take forward the One Health agenda for the betterment of humanity. And when we look at it from the context of COVID, the first point that I wanted to make is that we need to understand such epidemics and pandemics as to how they really emerge and develop a meta-synthetic framework on what really causes these epidemics and pandemics, and both at a human intervention level, spread and its control, and see how we can better control the epidemics and pandemics, develop a framework for it, systematic framework that can be taken forward to the community for being able to better control it. Other important thing that I wanted to say is, as we all know, the importance of One Health really to the entire community has come about because of COVID. A lot of changes have happened because of COVID. The way patients are now being treated, the community mobilization, the way we work, there have been significant changes. So we need to understand and learn from various experiences in tackling COVID all over the world. And from this, we have to draw lessons there can be for One Health in a holistic manner. So that's the second point that I wanted to make today. Another key aspect that I wanted to share with you, especially from an Indian perspective, that I am the Director General of the National Institute of Rural Development and Panchayat. It acts as a think tank for the Government of India Ministry of Rural Development and Panchayat. Thereby, we mean to say that we give them ideas on how ongoing rural development programs, for which there's an investment of 2 lakh crore rupees made by the government, which is substantial amount of money. How can we improve these programs, working with the community, the substantial part of our work and substantial part of work of the government. So one key aspect that happened during the previous COVID in India was that initially COVID in India happened as an urban phenomenon, mostly in the cities, Delhi and so on and so forth, from where it spread to the rural areas in the first wave of COVID. There was a second wave of COVID. In the second wave of COVID, we saw the converse, the COVID spreading from the rural areas into the urban areas, which goes to show that, look, when the first wave of COVID happened, a lot of the virus got incubated in the rural areas, and subsequently the second wave of COVID really came from the rural areas into urban areas. Therefore, one cannot neglect urban area or rural area of healthcare. When we talk about public health, both are equally important, and we need to realize the importance of both urban areas and rural areas. Urban areas cannot be immune to what diseases can spread from rural areas, and we have to find ways of tackling the diseases in the rural areas. And when we talk about One Health, one important mechanism is constant surveillance to understand that what new diseases are emerging, which have potential to become epidemics, which have transboundary kind of spread. And as we all know, looking at the vaccines, diagnostics, and therapeutics. So beyond that framework, we need to look at the community surveillance. Surveillance cannot only be left to the medical fraternity, but it has to go down to the community. Community as triggers, as pointers to say that, look, this kind of disease, this kind of abnormality is coming up. These kind of zoonotic diseases are coming up, and they need to be attended to, they need to be tackled. So we train the community to be able to do that effectively. Our surveillance burden will substantially come. That's something that we need to work on, along with training the community to perform the surveillance function, inform the medical functionaries on what is emerging, what's coming up. We also need to train them on coping with such kind of epidemics and pandemics. So how do we do this? And we in the National Institute of Rural Development have been looking forward to do that from several years. We've had a village disaster management plan exercise, which we developed, the framework of which we developed with the National Institute of Disaster Management. So, but unfortunately, that disaster management planning exercise really did not go to the community, did not go to the villages. If it had gone to the villages, if we've been able to develop well-trained volunteers in the villages, I think the impact of COVID would be much less. Productivity loss would have been much less. And that's what we're trying to do. Now take forward this village disaster management planning framework, taking also into consideration or a trained responder disaster management force coming. But a lot of time is taken. Global targets to achieve a poverty-free village and so on and so forth, a hunger-free world, like that. But coming down to the local community, what does it translate into? There's no clarity. So I think India is one of the few countries which has come up with local action to achieve sustainable development goals. How can each panchayat be asked to prepare a plan to achieve the sustainable development goals, such as achieving a poverty-free village, achieving a healthy village, a socially secure village? And when you talk about the localization sustainable development goals, one of the important themes out of the 9 themes involved by the Ministry of Panchayat Raj for all panchayats in the country is a healthy village. And here we expect the local sarpanchas and the panchayat leaders to provide leadership. The parity here is that they are the panchayat leaders either illiterate or semi-literate kind of people, expecting them to do take up various initiatives, achieve goals which are monitorable, achieve results which are monitorable. That becomes a challenge unless we give them a clear-cut framework in moving. And of course, they can just move towards the local. Also incorporated healthy village theme work that we are doing. So these are the experiences. How can we involve the community in surveillance towards one health and move towards preparing village disaster plans and also strengthen the systems that I wanted to place people and I'm very that the IIPH has come forward to organize this symposium. I'm also glad to see a number of veterinarians participate in the symposium because this is unique. Normally, we think in silos, even in the medical fraternity. So we're looking beyond those silos, bringing in a lot of veterinarians and other practitioners. And I'm very sure that with all these diverse range of participants participating in the symposium, this will be very successful and show us a new path for progress. Thank you very much.
Address stressing on the importance of One Health, especially after the COVID pandemic, and also suggesting ways for building resilience, especially at the community level, the village level, etc. And we know that, I mean, we are all gathered here and many of us know that One Health is a holistic approach. It emphasizes the interdependence of all life on this planet, which is human. This interconnectedness impacts our health, our communities, and our world. And according to design that allows various sectors to collaborate and communicate, ultimately leading to better public health outcomes as well as health outcomes. The goal of the symposium is to foster meaningful discussions, share cutting-edge research and insights, and collectively develop innovative strategies that leverage the One Health approach. We are all excited to have very meaningful discussions today, share the work that we have been involved in, also share the challenges that we face with each other in today's event. Over the next few hours, we will hear from the chairs, the panelists, and the participants. So we really encourage conversations among each other as well as among institutions as part of this and following this particular symposium. We are deeply grateful to everyone involved in making this event possible, especially the Cyrus Poonawalla Center for Infectious Diseases, which is based at IFAH Hyderabad, and our esteemed partners from the Oklahoma State University, USA. This collaboration underscores our commitment to global partnerships that bring expertise and experience and perspectives to the forefront. So a quick agenda for today's program. As you all have a copy of the agenda, I would like to re-emphasize that throughout the day, we will hear from prominent speakers and participate in interactive sessions focused on various facets of One Health. We encourage each of you to speak, engage, ask questions, especially the students and the scholars who come from outside also. And please exchange ideas that could spark new collaborations and actionable solutions going forward. After the break, we will start the panel discussions where we will discuss the various topics that are there in the symposium for each panel. We invite all of you and all the stakeholders to stay and contribute to the discussions, please. Now, without further ado, let me introduce Professor Jerry Malayar, who is Senior Associate Dean for Research and Graduate Education at the Oklahoma State University, USA, who will be formally welcoming us all to today's symposium with a keynote address. It's my honor to introduce Professor Malayar, who is the Senior Associate Dean for Research and Graduate Education in the College of Veterinary Medicine at OSU, where he also holds the position of Professor and McCasson Chair in the Department of Physiological Sciences. He has over 25 years of experience in academic veterinary medicine, including 20 years of experience in administration of multidisciplinary research and training programs. By appointment of the Governor of State of Oklahoma, Professor Malayar is also on the Oklahoma Science and Innovation Council and the Health Research Committee of the Oklahoma Center for the Advancement of Science and Technology. This is, by the way, a state agency for which the committee plays an advisory role. For 11 years until October 2021, he served as State Director for Oklahoma EPSCoR/IDEA and was a member and Vice Chair of the National EPSCoR IDEA Coalition Board of Directors, which is an organization representing 27 member states. Chair of the Research Committee of the Association of American Veterinary Medical Colleges a founding member of the Scientific Steering Committee for the Oklahoma Center for Adult Stem Cell Research, which is a program of the Oklahoma Tobacco Settlement Endowment Trust. He's also a member of the advisory board of the Oklahoma Center for Respiratory and Infectious Diseases at OSU, a member of the advisory board Oklahoma Nathan Shock Center on Aging at the Oklahoma Oklahoma University Health Sciences Center. He works with veterinary students, postgraduates, and faculty every day and has been principal advisor for a dozen PhD graduates and served on advisory committees for dozens more across multiple departments and disciplines. Professor Malayer has authored more than 70 peer-reviewed publications of original research. I welcome you, sir, and I request Dr. Rajan Shukla to present your plan.
Good morning. Thank you for that kind introduction. It's a great pleasure to be here. Three of my colleagues from Oklahoma State University are here. Thank you very much. I feel like I have one of the easiest jobs of the day. The task for this segment is to explain to you what One Health is. I don't think I need to go into much detail for this group. You know One Health. The previous speaker mentioned the Sustainable Development Goals. One Health and the UN Sustainable Development Goals go hand in hand. They are interleaved and inseparable in many respects. At Oklahoma State, we have programs in our medical school, our veterinary school, our College of Agriculture, College of Engineering, people, Native American tribes, as well as other groups who suffer from obesity, diabetes, diseases of aging, which are very important in our population. We have bioinformatics and data programming. It was important to analyze and interpret and understand the data and report the data on health, both in our animal as well as our human populations. We have a new program in microbiome science to understand the relationship between the microbes that inhabit our bodies and our environment and our own health and well-being. We have a Human Nutrition and Performance Institute related to how human activities in exercise biology and nutrition affect our long-term health, and also these diseases of aging and the interaction there. So all of these things fit within the umbrella of One Health. They all fit within the umbrella of the Sustainable Development Goals. If you think about the Sustainable Development Goals and the complexities that are inherent within them in terms of solving problems, these are a whole series of what we call huge multi-dimensional, multidisciplinary type problems for us to solve. If you think about the SDG number 1, which is no poverty, poverty typically entails poor housing, lack of food and animal feed, unsafe water, lack of health care, malaria. These are all highly prolific pathogens that affect the human population in unequal numbers based on we have Globally, we know that access to clean water, providing sustainable water management for those populations is a huge problem. And so forth. Animal and human health are directly affected. Things are now changing. And our relationships, the balances that have been created through our evolutionary history are changing. Understand how the evolution of the pathogens, the evolution of the vectors is affected by this, by these changes. So this brings up the idea of what kind of approaches do we take? These are, as I said, wicked problems. Disciplinary. These problems are the elephant. How are we going to take care of our elephant when one thinks it's a spear, another thinks it's a rope? We must understand the problem at the same version of the work together to understand the problem at the same level so that the expertise of each individual, the tools of each individual. Another analogy is a friend of mine and I worked on a multi-transdisciplinary project. And we described a multi-transdisciplinary project. And we described our first meeting as everyone came to the meeting with their rock. And they put their rock on the table. This is my answer to the problem. They put it on the table. And they defended their rock. We defended them very hard, very vigorously. And at the end of the day, we didn't have an answer to our problem. We had bag of rocks. So we want to get past the point of collecting bags of rocks and begin to understand these problems at a much rocks and begin to understand these problems at a much more sophisticated level, bring all of the disciplines together in order to understand. And let's do not forget the social sciences, the humanities. Let's don't forget the historical context, the cultural, the economics of it will dictate almost everything in the end. Because politicians and business people and others make decisions based on economics. Where's the money going to come from? Who's got the money? And then how do we address the problem? So these are all very important components. I hope in the discussions today, you'll take into consideration the need to look at things in this multidimensional way and not distract you. I appreciate the opportunity.
Disciplinary resource, and for us to need to bring in various perspectives, including the social sciences, the economical, the societal perspectives and all. What we will do now is to break for tea for 10 minutes. And since we are running behind schedule for about 10-15 minutes, so I urge you to have conversations or start conversations, have a cup of tea, and please come back here in about 10 is served right here in the room next to us. Here in about 10 minutes, maximum 15 minutes. Thank you. I'll get in touch with you. Yeah, part of these innovations and correct. So we are part of science and definitely. I mean, that's the idea for me here as well. Even we have been talking with we have to see how we can because there's a lot of things happening in pockets. That's exactly the whole idea because in India, one is the national mission. Our sister entities in Pune and Bengaluru have been doing that in blood city level. But in Hyderabad, it's not much of action. Yes. Correct. AMR is that's right. It's yes.
Recording in progress.
Okay, welcome back, everyone. Thank you. Okay, so now it is time for our first panel discussion. And the topic of discussion is innovative approaches to health research. A brief introduction. Professor Yogeshwari is a distinguished faculty member at the Department of Pharmacy at BITS Pilani Hyderabad campus. She is highly regarded in the field of medicinal chemistry, particularly for her work in drug discovery and development. Her research focuses on various aspects of medicinal chemistry, including the design and synthesis of novel small molecules targeting diseases such as cancer, tuberculosis, and neurodegenerative disorders. Dr. Yogeshwari has contributed extensively to the scientific community with numerous publications in high-impact journals. Her research often combines synthetic organic chemistry with pharmacological evaluations, aiming to discover new therapeutic agents. She has received various awards and recognition for her work, including grants from the government and private research bodies, which support her innovative research in drug development. Additionally, she has been involved in collaborations with national and international institutions, further enhancing the impact of her research in medicinal chemistry. I now kindly request the chair to invite and introduce the esteemed panel members for the panel discussion, and the topic again, innovative approaches to One Health research. Over to you, ma'am. Thank you.
Am I audible now? Yeah. So very nice morning, very good morning. And I see a lot of students sitting behind and thinking that they're going to get a lot of insights from the speakers as well as the panelists, right? And I just want to make all of you feel ease, because I'm also one of the participants. Though I stand here, doesn't mean that I'm going to preach something which is going to be very important, but this panel discussion is going to be more interactive and it is going to be more simple. There are two reasons for this. Why? I was thinking I'm the only odd person out here, because when I entered IIPH, I was introduced to a group of experts in veterinary science. And I was thinking, what am I doing here? Because I'm truly doing something for human health. And I'm going to be among the veterinary science and we're going to talk about animal health, right? But then I felt very ease because of the topic that is given, which is One Health, which is for our nation as well as for the world, going forward, because this is what will sustain a healthy world. Because if you are only concerned about human health, we don't bother about what is happening with animal. I'll just give you an example which everybody will relate. COVID pandemic, right? We all worried about when will the vaccine come, when will the drug come, if at all somebody gets COVID in your family, we started isolating them. We were concerned, right? People went through depressions and all that. People who have pets, how many of you have pets in your, this is just a family, right? And then we talk about the community. First for what we do, what we think, how we react. So how many of you have pets at home? Nobody? There are only two people. Okay, no problem. So when vaccines came, we all got vaccinated. And what about our another family member who's a pet? And people who have pet or who do not have pet have always, one is fear from the animal itself. Second is what will happen if the pet gets some infection, the fur will cause asthma, the pet, if they lick you, then you get infection, right? So some of us do not have pets, most of you do not have pets, possibly for that reason, right? So this is one example where we never bothered about what will happen to a pet, right? So who will discover? So me being from pharmacy background, where pharmaceuticals, biotechnologists, I know what they do as research, but I don't have any clue who will actually discover a vaccine for these animals. Right? We are concerned. If the animal gets COVID, one is not a fear that we will get through because we treat them as a loved ones. But what if we lose the animal, right? So that's a fear, right? So we never, first of all, our family. Now coming to community, because most of you do not have pets. We all depend on plant and animals for our nutrition, right? Every day we buy milk. Is there anybody who do not buy milk at home? There is nobody, right? Either the packed milk or fresh milk. So how many of us really relate if there is any disorder in the human just because of just consuming milk? I'm not saying milk is bad, good. I'm not here to say that. There's a lot of things which can get transmitted through milk. Forget about infection. First of all, we always believe that pasteurized milk are safe. Fine, yes. But what about your metabolism? Do we even think about whether animals have well spoken? Now it is very, very well, visible. As PCOD is very common. People think that even a born child can have PCOD. Does animal do not have? Do they not have hormone? And how do we discover drug? If I come from my own research background, first we test in animals. If it is safe, we call this preclinical. Only then we go to the human clinical study. So which means that the animals, once they are safe, all the safety studies we do with animals, and then we go to human, right? So we know animals can develop diabetes, animals can develop depression, animals interrelated thoughts which is coming. This is only because I'm among the veterinary science, I'm trying to relate, isn't it? So that is what this conference platform has given all of us to appreciate what the other person is doing. They come from different background. I'm not an expert in veterinary science. I'm not an expert in data science. One of the panel members is going to be joining today. I want all the panel members whom I'm going to call now to be cool because we are going to explore ourselves first thing, what we do, appreciate each other and see how we can collaborate and make this as one of the agenda item because unless you collaborate interdisciplinary, we are not going to achieve anything very close to One Health. We have to connect everything. Biodiversity doesn't only mean plants, animals, and human, it's also environment. So during the tea break, we had a small discussion of how all of us, when we all buy medicines, right? We all have a handful of medication, whether it's painkiller or for allergy or whatever. We don't bother about whether this medicine expires, or do we even check whether it expires? You check. You keep the whole strip always. We cut, right? One tablet, two tablet, we always, and then there is three tablets left out, and we do not know. Maybe the expiry date wala has got on already. It is not that I'm talking about that expired medicine will harm us. It's not that. Expired or unexpired drug, when you actually put in your dustbin, after that what happens? Where does it go? It goes to your ground, the earth. Do you know how it is? It exploits the water. So the same water is recycled, we drink. We say it is all filtered, RO water. Do anybody talk about the chemicals which are there? We don't think about it. I don't think about it as a researcher, because we think somebody else will think about it. Environmentalists will think about it, right? So everybody has their own expertise, own agenda, but today this is going to be a common platform for all of us to promise that yes, I do this, but I'm also concerned about what happens next, right? If I do pharmacy for human health, I also should be concerned about veterinary science as well, right? The same drug, different dose, it might be useful for these animal for as an antimicrobial or anti-cancer or whatever, right? And then what happens to the drug when it is put in the environment, isn't it? That is also your responsibility. We think that somebody else will take care, right? So let me introduce the panelists and then we continue the discussion. Fine? All of you are feeling at ease? I'm not talking anything technically, complicated topic. It is very, very easy topic for all of us to understand and listen. And I want all of you to participate. I want you to ask questions to the panel members so that it becomes more interactive and more engaging. First, let me introduce the first panelist, Professor Raghupati Anchala. He is a Dean Academics, IIPH Hyderabad. He is an expert of public health and primary care and also a physician. Please take your seat. What is interesting is, he's also a passionate teacher. That means he can also tell stories and relate what we see in everyday life. He has a proven track record in implementation and operational research, and he has adapted a program in management and establishing industry and academic collaborations. And he has been instrumental in driving the MPH program, which is Masters of Public Health program, and placement of numerous students pursuing MPH. Thank you, sir, for joining. The second panel member is Dr. Rudra Gowda, whom I met, and I was little feeling odd because he was already discussing something on veterinary science, and I just entered, and I'm trying to sync with these people, and of course, we all will, at the end of this panel discussion, we all will think alike, we all will work together. Dr. Rudra Gowda is a PhD and is an assistant professor in viral immunology and veterinary pathology at the College of Veterinary Medicine, Oklahoma State University, where he has an active research program that focuses on coronavirus host interactions and evaluation of antiviral, anti-inflammatory agents to reduce the disease. He has also developed a research program aimed to understand the basis for severe coronavirus disease in the elderly. The third panel member, don't feel you're an odd person in this panel. She is a data scientist. Ms. Subhashini, she is a lecturer in IIPH Hyderabad. She holds a master's in biopharmaceutical technology and is a certified base and advanced SAS programmer. Before joining IIPH, she has held notable positions in various sectors, including academia, insurance, banking, and research. She has been serving as a guest lecturer at SRM School of Public Health earlier, also served as a senior specialist in insurance data analytics at Thomson Reuters Truven Health Analytics, and associate manager in the risk analytics department at Scope International. So she's totally an IT person, but she has a master's in biopharmaceutical, so somewhere she sings with us, but when I discussed with her during the tea break, she said, please don't ask me anything about the science. I am good at data. I said, please feel at ease. We all will talk what we are best at. and we all will try to connect with each other and then see that how innovations in One Health research can be taken forward. With this, let me take my seat. I hope I'll be given a mic there, or should I stand in? I can take that? Okay. So that I. Hello. Yeah, so to continue with the panel discussion, have done enough speaking. I think you should not be bored. And I'll give some 5 to 6 minutes to each of the panelists so that I want them to tell what kind of work they do, and then how do they look at One Health program being an expert in a particular area of research.
Good morning, everybody. I think briefly we covered the way forward and the challenges faced in One Health domain from the implementation science of point of view. So looking at challenges in One Health, one of the biggest challenge is the cross-cutting area. Am I audible now? Okay, thank you. So, I was talking about the challenges faced in One Health domain with respect to implementation sciences. One of the biggest issue with One Health is that it is not although it is a cross-cutting area, most of the domains work in silos. All of you understand silos, but here it is all the more pragmatic from the point of view. It becomes difficult for a scientist working in, say, poultry sciences or zoonotic diseases to talk with other medical people, or for example, from the public health point of view. So by governance, since I'm working in the operational domain of public health national programs, all of us understand the importance of a key architecture under an umbrella framework. When we work with the governance mechanisms in mind, we need to keep in mind that if you do not have a clear-cut objective and values attached to One Health program, then it is bound to flounder in the areas of implementation sciences. So second biggest challenge is lack of a framework of governance in which the objectives and values are not clear to everybody. So with these two challenges, the third or experience in national program is the 4 C's of any kind of national program, be it the coordination, be it the collaboration, be it the communication or capacity building. 4 C's which are to improve One Health functioning in the government system. In terms of collaboration, usually the North-South collaborations drive most of global health agenda. And since global health diplomacy is picking up, we have seen wonderful examples from Philippines which work in the area of One Health. So way back in 2020, the Philippines government called an expert panel for all One Health people, and they all understood that we need to change the nomenclature of community health worker to One Health worker. So this is an exemplary example of trying to build capacity for frontline healthcare workers in the One Health domain. By this One Health worker concept, in which they have renamed the community health worker as One Health worker. So this One Health worker not only works on the medical data plane, but also works on sociological and community point of view. What they have done in Philippines is an exemplary example in trying to make sure that communities are the focus of One Health. So using principles of sociological sciences, all the students must be aware of community diagnosis, in which we try to understand what are the needs of community. So this high-level technical committee in Philippines had commissioned people even from society as a part of that particular team. So using the grassroots workers, they try to find out from the community what is their viewpoint of One Health. And they were shocked to know that the advocacy and awareness of One Health was almost minimal in the population. Just like all of us scientists, experts working in One Health domain, all of us are very good in the medical science of One Health, trying to find out what infections can happen, what pandemics can be triggered by lack of appropriate framework and structure. But if you don't involve the community as a part of One Health programs, then they will not be in the longer run sustainable. We have talked about sustainable development goals. And all of us need to understand that sustainability is the key of One Health program. We have seen programs, national programs in tuberculosis, HIV. They have taken up to a different level because they involve the community. The national program for NCDs also is trying to work on trying to involve people living with NCD conditions. So utilizing community is a good example as a way forward in the One Health domain. And last but not the least, such kind of examples of good case studies need to be discussed much more in the One Health forum. So as I mentioned, collaboration, South-South partnerships. So Philippines and say Cambodia have partnered for the program. There is a scientist called Professor Renzo Gunto, who uh, who has joined Duke University in Singapore, and he has coined a specific term. I mean, it's a term known to all of us, but he calls himself a planetary scientist. So when I interaction with him, what is this planetary science? So nothing but One Health, in which they try to cover all the domains of One Health under one umbrella. And he has implemented that program in his own country of Philippines. And this example came while I was discussing with him on the One Health concept. So that's a way forward for us to involve the community and also to make sure that we have the objectives and values clearly lined up. So as I mentioned, I would summarize that the four C's are very important in One Health domain. Capacity building of frontline health from both from medical and non-medical, I mean by non-medical I mean sociological point of view. So if you build the capacity, then collaborations, communications and coordination are easy to follow. Okay, with that I'll take care. We take the lead.
Thank you, Mr.
Almost good afternoon, everybody. My name is Rudragoda Chanapanawar. I'm a veterinarian by training, far from here. I graduated from Bidar Veterinary College, just 3 hours west of here. I'm from Karnataka originally and did my master's degree in veterinary pathology from Indian Veterinary Research Institute in IVRI, Bareilly, Uttar Pradesh. Then I went to the US for a PhD, and then I did postdoctoral studies, and for the last 5 years I've been a faculty member, initially at University of Tennessee and in a College of Veterinary Medicine in Oklahoma State University. So thanks to Dr. Cole for organizing this meeting, and thanks for all those who were involved in organizing Ms. Roshni and Dr. Tetalapi as well for facilitating this work. We're really happy to be here to share our thoughts on One Health and innovative approaches. So what do? I'm a veterinarian, but I work on human pathogens, coronaviruses. I've been working with coronaviruses since 2012. It's been 12 years I've been working with coronaviruses. I initially worked with SARS coronavirus, then MERS coronavirus, and as the pandemic hit, we all got on our gear to work on SARS-CoV-2 as well. I'm a virologist and a viral immunologist by training. The specifics of my work is to identify why these viruses are pathogenic in humans as well as in animals, and what can we do to develop new therapeutics to treat these animal as well as human coronavirus diseases. And now I'm more respiratory infection guy, and not only limiting myself to the coronaviruses, but we're also studying several other respiratory viruses. And I also work a lot on vaccine development, preclinical models specifically. I have worked with some companies as the pandemic hit to test their vaccines, antiviral veterinarian, works on human diseases. I kind of have expertise a little bit on zoonosis and zoonotic diseases and how to prevent them. And by that, I mean how to prevent infectious diseases both in animals as well as humans. So as we go along, I'll share some of my thoughts about what can we do to protect One Health, health of animals and humans as well as the ecosystem that we live in. So we have some points I have made, which as we get along, we discuss those points. Thank you so much.
I'm here. I'm from Center for Digital Public Health, IAPH Center for Digital Public Health. So here I'm going to discuss about the data management perspective of One Health. So this One Health is an interconnected and they are interlinked. I see it as a horizontal perspective of interlinking the data. For which we need a database. To have a proper, robust database, we have to collect the data. So through this forum, like it will be good, like we connect and collect the data from various institutes around. So the database becomes robust. Once the database becomes robust, we can send bulk SMS alerts to the people who are affected, not only the people who are affected, and also the intersector. For instance, there was a bird flu outbreak where not only concerned affected veterinary people, but also the humans were affected. So we can send bulk broadcast messages, alerts to the people who are affected. And also like we can have a model so that we can address the future outbreaks. So through this data visualization and analytics, we can have a proper insight of the diseases. Apart from this, once with the database we have created, we can have a technology like various GIS and Panda like that, and we can analyze the data, and we can have a data integration through which we can monitor and analyze the data, evaluate the data. Here comes the data governance. The data governance means how securely and how safely we handle access the data. By this we can have the open data platform where we can have the we can have interdisciplinary collaboration of data and analysis. So for which we should have a frequent meeting and discussion so that we can create a robust database. Thank you.
Thank you, Mr. Yeah, so now you know who are sitting here. So we have a public health expert, we have a veterinary scientist, and then we also have a data, handler. Now, since we all of us can connect to the pandemic, everybody, people who are not even, layman became doctors because of WhatsApp. Forwards, people can read what is COVID. They talk about COVID more than the experts itself, right? So I just want to, because it's innovation, I just want to put to the panel members to give their thought about the pandemic, which everybody have got exposed, right? We all knew what it was broadcasted, what was happening throughout the world, because news channels, social media, we are in that era, right? So I just want to ask the panel members one by one, just to share a thought, what could have been done better during this pandemic if all of us as stakeholders of One Health would have worked together, both the data scientists, veterinary scientists, public health workers. What would have been better? We don't have an environmentalist. I think we should also think about it, because this is my perspective is we all try to protect people. We started talking about social distancing. We started talking about what is the importance of wearing a mask. But then, though it was followed, not followed, there's a different thing. There were even cameras made, AI cameras, which can even detect in a group of big crowd if somebody is not wearing a mask in airports and all that. So people could even get the temperature sense at a distance, right? The airports had a lot of cameras. So there were a lot of technologies used, a lot of data broadcasting happened. But I don't think we worked towards something called as a sustainable One Health concept there, right? Because it was a pandemic, it was not expected. But having seen what has happened, what has happened well, what has happened not well, I just want to ask the panelists, if at all we all came together to work together, integrated our thought process, what would have been better, what would have been avoided?
I think the COVID-19 pandemic gave us this term of infodemic, in which data was quite fictitious. So the data platforms, even though they were running in real time, basis do not portray real-time data from different parts of India. So that led to a communication barrier between the community and the scientists working on the COVID-19 platform. Now, from public health point of view, I think if we all work together as a team perspective, it's important for us to portray the importance of correct communication channels. Who should communicate? What should be communicated? Should be very crystal clear in black and white so that the community at large knows in general what are the potential early warning signals which need to be taken into account. Second big thing which COVID taught us was the importance of coordination between different sectors. The medical sector was galvanized into action based on the COVID-19 pandemic. But what did not actually take place was the infrastructure backup in the second wave. All of us saw the dead bodies putting down the Ganges River in the eastern part of UP. So such kind of scenarios could have been avoided if we had planned better based on infrastructure requirements for which we were not adequately prepared. And that is how only if it's a unified command center which will have all the actionable elements required so that an actionable report can be portrayed to the community at large and the community and the scientific experts can work as a team together to prevent further outbreaks in the future. And the third thing which was very important was the usage of GIS platforms. It was a novel idea which came from some countries in the Western world. But India took a lead in trying to portray early models for what will happen if prevention steps are not taken. So some parts of India, like Tamil Nadu, Karnataka, and even Telangana and AP, developed GIS models based on early prediction patterns, which showed us if the pandemic is controlled in X point, then the wild population will not be affected. Such kind of data generation is very important in future communication models for the public at large.
Thank you. So from my perspective, as someone who works on infectious diseases, I think what would we have done? I think one of the necessity was the clarity in the message that the administrators as well as the health professionals provided. There was no clarity and there was no consistency in the message the public got. As a result, there was always a confusion or a question, and the regulations were not properly followed. So that was the one which I think was important. And I also see not only for COVID-19, SARS-CoV-2 virus initial period, but also for a lot of animal diseases. We don't report a lot of diseases. There are still a lot of animal diseases which researchers know they exist, but we don't report those to World Health agencies or other regulatory bodies. For some reason, we hold those back for a political reason or some business reasons, the export and import of the product, meat products, and so forth. I think those could have done better in those proper reporting of initial cases of the COVID-19, how much really was impacting. I think that would have been a really important step taken to alert the seriousness of the disease, which we did not do initially, both in the US as well as in India. I think that would be an important point. Another key aspect would have been funding from the government and public health agencies for diagnosis. There was a lot of issues. The diagnosis was not done properly, on time, because there was not much funding. There was no health professionals or diagnostic people who could do the diagnosis early on, provide the results, and so that we have to take care of these people. Funding for research is still a concern in subcontinent, and funding for public health agencies. That's one of the biggest problems. If there was funding, there would be more professionals, more guidelines that are being developed that would have been really important. Education of public on public health, zoonotic health, I think one of those public health officials can do and can do much better, where you tell them how to protect yourself in case of epidemic or pandemic or even small or sporadic outbreaks of diseases that one can do. And I think a kind of clear, streamlined public health infrastructure, I think could have been better. I hope we have learned our lessons from the pandemic. If not, I think we will be ready for another pandemic. A streamlined, cutting red tape public health infrastructure clarity in the message from the public health perspective. I think that is really important for us. Just to give an example, we had a colleague in North Carolina who worked with we measure the person I worked with during initial years of coronavirus was one of the leading experts in the world. He still is my mentor, Dr. Stanley Perman. And there was another lab in North Carolina, University of North Carolina, Dr. Rob Barrett, so whom I know well. They published a paper probably in 2019, if I'm, or 2017, if I'm correct, where they did clearly write in their paper that they have identified the coronaviruses in bats that can bind to human receptors and they can jump into the humans, may cause pandemic. The signs were there, but the public health people did not listen to those signs. So that I think public health officials and the politicians need to more listen to what researchers say and follow up on those. I think those are few things that we could have done better throughout the world to prevent the pandemic. And these are necessary to prevent these pandemic or epidemic occurring in the future.
Here we are actively working on creating an observatory for One Health, for which I feel we should have a interdisciplinary collaboration with the various institutes. So for which what is important is to understand the data governance. Data governance means how we are ethically and responsibly sharing and accessing the data. So once we understand the data governance, we can definitely work on like open data platforms where we can collaboratively analyze and research the situation, the pandemic outbreaks, whatever it is. What we want is like we have to have a frequent meeting and we have to construct our database a robust one.
Our guest of honor have mentioned that we should create healthy villages, which is a possibility, right? So you can start small and within the community that we work. In case we all of us, along with environmentalists, social workers, or social scientists, economists, professors or scientists come together. How do we start? What are the checklists that we need to do to start small? You can give briefly few points. If we start building One Health as a program for creating a healthy village, to start small, what is the checklist that you will start looking at when we all come together?
One key change required is community empowerment. As I often said, Chinese community depends on how you interact with the community. So if you're starting a healthy village concept, it's important for the community to be equally empowered about the early warning signals and what needs to be taken to prevent such episodes in the future. The second thing which we must advocate for is having good infrastructure at the village level in terms of program management. Though the health system has got adequate infrastructure and adequate personnel, not everybody is competent enough to understand and appreciate the importance of One Health. So when we go back to our training, it's important for the frontline healthcare workers to be equally empowered with what are the required competencies to provide good One Health support for the village. So one is community diagnosis and second is to empower the frontline healthcare workers with the required competencies for One Health management.
So I just want to, I think, at the village level, I think we need to have a better health system, diagnostic system to identify the diseases that may come up, and so that those can be reported and further action can be taken to prevent the transmission of these zoonotic and other diseases.
The CHW should be empowered with the latest technology in mobile, how to create the work on the application, how to fill the data properly using mobile. So it is very important because what they feel is very crucial to understand the situation better.
So just for my information, because we have veterinary scientists, public health worker, data scientists, I know that everywhere we have primary health center depending upon the community population, right? But do we also have a system where to report environmental, like say for example, whether the water, drinking water is safe, hygiene? Does the primary health care takes care, or do we have system where there is a reporting of environmental toxins available? Second is also about the animal health. Do we also have primary health care units for animals in that community?
Probably I'm not expert to answer this question. I want. It is very important for sure. Whether do we have it, I don't know. So what I because I've lived almost 17 years in the US now, so my apologies. But having said that, we definitely need systems. I can give you a couple examples here. So what are we doing after the pandemic in the US? So now we have established a really good surveillance system. So what does it mean? It collects the samples from sewage that are centrally collected in each counties, each towns. So they collect the sewer, they look this, they collect it, isolate, RNA, DNA, and sequence it. So one of the advanced technologies now that we're doing. They sequence it to identify, for example, during coronavirus, the coronavirus was changing. There's one variant of the next variant of the next variant. There are a lot of researchers who are collecting the sewer samples, both from animal sewer shells and human waste, excreta, and so forth. Sequence those samples to identify if there is a prevalence of one of the variants. Is there a new emerging variant coming up? And we are still doing that. Those systems are giving us a clue that someone in this big population in the village or in the district level or state level, someone or a group of people are infected with this virus. This virus is circulating, and it may emerge, and it may transmit to the different individuals. And sometimes it may even transmit back to the humans, animals. So I think that kind of surveillance system probably will be really helpful. It takes some infrastructure build up, but I think that can be done. That helps us to track these different variants or new viruses or other bacteria, other pathogens to detect these pathogens and probably report them and maybe prepare for the emergence of these species into humans or from humans to animals. I think that's one of the things we could do to really help. And again, data scientists are really key here because they analyze the sequences and identify what kind of pathogen is this one. So those will be helpful. I think if we can implement, if you haven't already in here, that would be really helpful to track the new pathogens and maybe take the correct measures.
So, like, I would like to share an example. There was using spatial data analysis. We collected, like dump sites where the sewers are down. We collected the points from the corporation, and we thought we will analyze the health of the people around. And later we found using GIS that the dump site was not the particular site where they had mentioned, and it was in a various other places, and it didn't work. So GIS really helped us to really exactly level. So always I emphasize on data, which is very crucial.
Can we open this thing to discuss? If any curiosity driven questions are encouraged. Monitoring One Health, do we have a list of required data, or does it have to be worked? Any idea on that?
So far, no. We are actively working on, creating a database for which we need to, have a collaborative approach with the various institutes. So for which we have to first understand the data governance, like what has to be shared and what not be shared. So this is the inhibition that everybody has before sharing the data. So once we have a proper guidelines, which ICMR and also AVDM is working on, once we understand and we empower ourselves data governance, definitely we can work on it. Thank you. Hope I answered your question.
Are the variables understood? What
I got that. I can take one more question.
We have things lined up for the tertiary case sector, but for the primary case sector, very good criteria for
Or you can go here. Half a comment and half a question, and it's not answered, it's fine. The focus seems to be all on outcomes and objective measures. But when you think of one, it's really wide. And the foundations of all those outcomes are also important to understand. So people's beliefs, behaviors, practices, how they're interacting with plants, animals, and chemicals in the world. So we need some research on that as well, rather than just focusing on diseases and amounts, parts per million in water and so on.
We are living in a diverse country, and village to village there will be behavioral changes, practices, beliefs, and all that. I think that is why I said if you start small, start with one point which is common. I think somewhere we have to start, right? So yeah, question. Thank you. Yeah, so I'll take that as the last question. Veterinary sciences who's also in working in human health. Is there an understanding of the level of transmission from zoonotic to human health? Is there well done research which gives us the risk prediction of what are the kind of transmission that happens and what are the factors that impact this transmission, and what does the current science say, and what are the kind of risks that are more critical? Thank you.
For asking. I had that on my note, but I did not bring it up. So we do. The answer is yes and no. Yes, because we have recently, in the last few years, have done a phenomenal job collecting the data from both animals and humans that are about the viruses and other bacteria and other infections, where there is a lot of pathogens have been detected that were not initially identified. And interactions with the wild animals and exotic animals, there are a lot of animals that harbor a lot of different pathogens. Just to give an example, there was one study last month in May that the researchers from China, as well as a whole lot wild and exotic animals, they found out several hundreds of viruses that are not known to impact humans that are present in those animals. These animals are reservoirs for those, and they have the potential to jump from animals to humans, which we did not know initially. So there are efforts going on in that direction, but I think from each perspective of each country, the animal population, whether it's exotic, domestic, or so, is quite different, and they may harbor different pathogens. So I think one of the efforts should be to collect different samples from different animals and really have the ability to try. Definitely, those efforts are our ecosystem to not to try to interfere as much with the natural kind of system. The more we do deforestation and so forth, the more we're going to find these out. But again, it's really important to identify, sequence samples from these tissues and other.
Is the science to understand how to be able to predict what you get all the samples and the data? Is that then the follow-up steps easy to understand or predict? Is that
so the system is established, okay. But we're seeing new challenges for those which are not established. For those which is not already, or for those is well established. The one I gave you hundreds of viruses. Right. For those they did not know whether they can transmit from humans to animals and they can bind to human cells or not. Those are established. But there are a lot of the viruses which for which we don't know. That's why answer is yes, sir. Thank you.
Just to add to what Professor Rudra said, many of the virus diseases in India, so I worked with one virus for drug discoveries, Japanese encephalitis virus. So when I was collaborating with a doctor in NIMHANS in Bangalore, I was curious to know why are we even talking about Japanese encephalitis virus in India, because this is 20 years ago when I started working. So he's told me an interesting story. This virus actually was through a migratory bird, right? The farm, which used to come and settle in near a farm, and the farmland, water, all got infested. So there are many things that is we do not have data or source for it. And currently, since we are with a lot of integrated digital literatures available, I think it's easy for us to now trap, as was what she said, is how does the virus adapt or mutate to even survive in human? Because that is something which is interesting science. Thank you for answering and thank you for questions. Just to sum up, I'm so happy that IAPH had given this platform for all of us from different fields to come on a single platform. And since the topic is innovation, whatever we do in India will be innovation, because there are, for one hand, we are very, very far, because for the first thing is the expert itself has to come together, right? We are comfortable with working with the same kind of area, same kind of researchers. But I think this platform, I have decided that I will, push myself to interact with veterinary scientists, social workers, to understand public health experts, to see that how a small community can, we can start small, and that is why the question came up, just to see the checklist. Innovation, bringing people from diverse field itself is an innovation. This panel itself, I feel that for us to understand each other and what is our different perspective itself is novel for all of us. And I thank all the panel members. And one thing that I want to appreciate, which Professor Raghav brought in, is instead of we labeling us as medical doctors, human or veterinary scientists, it is always good to have a professional called as One Health professional. So that, which means that the professional do work with, integrate, they work with other experts, and they know what is the next step, right? Instead of saying that this is not my work, to worry about expired medicine put into the environment, I will know whom to connect, right? So that's a good thing, that is a takeaway for me from this panel. Thank you very much for patience.
Thank you for that excellent panel discussion. I thank the chair as well as the panel members for that wonderfully made points. And we saw that we got various perspectives from the pharmacy background, from the public health background, from the veterinary sciences background, as well as from the data sciences background. So that tied in very well with the topic itself, which was innovative approaches on One Health research. So now it is time for us to move on to the second panel for the day. We have two panels actually before lunch now. So I request the panelists as well as the chair to please see that if you can wrap it up in about 40 to 45 minutes, so that we'll be in time for lunch. So now I will go ahead with the next panel. I'm honored to invite our esteemed chair for the next panel, Dr. Raman Muthuswamy, CIMATS Chennai, which is Savita Institute of Medical and Technical Sciences, to the stage to moderate the discussion, which is on emerging infectious diseases, a One Health approach. Dr. Raman Muthuswamy, please, sir. And I would request Dr. Raghu to give Dr. Raman the line, please. while I do the introduction. Dr. Raman Muthuswamy is currently a research professor and cluster head of One Health and AMR with 36 years of experience. With 36 years of experience as teaching and research faculty in the Tamil Nadu Veterinary University and Savitha Medical Sciences University, Chennai. Professor Raman led 26 extramural research grants as PI, funded by British BBSRC, UKRI, as well as US-based BMGF and NIH, DBT, DST, and ICAR. His major One Health project includes GCRF, One Health Hub, led by Royal Veterinary College UK, and TMRC NIH grant, led by CMC Vellore, and ARC Discovery Project, led by Australia National University. Professor Raman has been awarded the Best Scientist Award by the Tamil Nadu State Council for Science and Technology in 2002, as well as Biotechnology Overseas Associateship Award by DBT, Government of India in 2006, as well as the Best University Teacher in 2006. He has an unblemished 60 plus years service award by the Government of Tamil Nadu in 2019, the Best Scientist Award by Savitha University in 2023, and he is the Fellow of Antiviral Research Society 2024 awardee, to mention a few. He is also an editorial member of AMR Journal, Frontier in Veterinary Sciences, International and Indian Journal of Public Health. Now I kindly request the chair, Dr. Raman, to please invite and introduce the esteemed panel members for the panel discussion, which is Emerging Infectious Diseases, a One Health Perspective. Thank you. Over to you, sir.
Good morning to everyone. So, because we are already a bit late, so I'm making it short. So the topic that we are going to discuss are emerging infectious diseases, One Health perspective. So why do we need One Health perspective for emerging infectious diseases? You all know that when we have veterinarians and medical physicians, why do we need One Health? Because basically the emerging infectious diseases doesn't mean that the diseases which are, infecting only one person. But now we saw that just the example of one viral infection, COVID, where we had to call everyone on to manage the situation, right from the physician, the public health personnel, the doctors, even the civic authorities, policemen, and even the public. So the emerging infectious diseases need not be unique. You need not be a single host. For example, we have been foodborne disease. We heard about foodborne infections. Since foodborne infections, do you think that it is emerging? It is emerging. We consume a lot of meat. For example, chicken meat. So, in fact, in one of my research grant, I was working in the value chain of the commercial chicken. So, what happened? These commercial chickens are fed with growth promoters, and some of them add some antibiotics as a growth promoter. So, what happens when these chickens are fed with antibiotics over a period of time as growth promoter? They end up in resistant pathogens in their gut as well as in all their value chain. So these chickens, when consumed by humans, and we love chickens, most of us, right? So what happened that these resistant pathogens are carried away to us. So this is just one example. So it may happen in any food animal. Because as you know that there is no strict implementation of dispensing of drugs over the counter. If you want to have some drugs, you can go to any medical shop, get it over the counter. So this is very common in human. Think of farmers who are located far away from cities. So when they have some problem for animals, the first thing is, though the veterinarians are available on call, but still there are time. So they have immediately approached the local pharmacy or the person who dispense the medicine and then get the antibiotics or drugs without knowing the consequences. So this is definitely an emerging infectious disease. Don't think that it's only the viral pathogens or even bacterial pathogens. And I have been working on Mycobacterium tuberculosis. You all know tuberculosis is very common in human beings and animals. See, the government of India and the entire world is now trying to eliminate or eradicate TB. But we come to know that the Mycobacterium species, which is present in human, comes from animal. But we never know the Mycobacterium tuberculosis, which is the species of human, also transmitted to animals. And in fact, we have been working on this tuberculosis problem in animals, especially in shelters. You all know that in India, most of the dilapidated animal or animals which met with an accident or disowned animals, where do they go? Where do these cattle are taken? Have you heard about goshalas? Shelters. So these shelters are, it's a concentrated place where hundreds of thousands of animals. Even in the city of Chennai where I live, we have a place where we have 4,000 plus animals in about 10 acres of land in animal shelter. So what happens? These background of these animals we really do not know whether they suffer from any infection or they carry any infectious pathogen. But all these animals are kept together in a small place for a longer time. So what happened? These pathogens get exchanged between themselves, and not only that, to the humans who are going as a volunteer or sponsors. They go every week, weekends, go to the goshalas, help by feeding the animal directly. You see, it's very common practice. People always feed animal fodder or some greens or banana, they directly feed. So what happened? There is no control of access of these humans or volunteers, animals, routinely. So we found that even among the mycobacteria, we were thinking only M. tuberculosis to animals and Mycobacterium bovis to human. But we found pathogens like Mycobacterium orygens, which is basically never considered as zoonotic. Now there are a lot of evidence has been generated both in the animals and also in human. It is not just that we happen to normally do a lot of postmortem in the veterinary college where I worked earlier. So we normally get a lot of deers which are accidentally killed or which died to some diseases in the Guinea. In Guinea, we have the official residence of the government where it is a lunch space for the entire Chennai. So they have lots of deers. So some of these deers we happen to do the postmortem and found they carry the Mycobacterium orygens. So how do these Mycobacterium orygens enter into the deer population, which is in a protected area? This is governor residence. How do they enter? So this is exactly what is happening in the environment. So emerging infectious diseases doesn't mean that animals are humans, but also environment. In fact, I was talking to Madam, the Joint Director, that the environment is the common platform that we are using the plants, the marine, the human, everyone, animal. So what happened? We are indirectly spoiling the platform, the common platform. So the emerging infectious diseases, it's a very broad terminology. So naturally, this needs a multidisciplinary One Health approach. Otherwise, how can we control or manage the kind of the pathogens or the emerging infectious diseases that might come through foodborne or vector-borne? Say, for example, I've been working on a government-funded project on filariasis. You all know about filariasis, human filariasis, and animal also have filariasis. What happened? We were randomly screening the blood samples of the canines, dogs in certain parts of Kerala and Tamil Nadu. We found that some of these pathogens originate from human. So we found some of the third stage infective or the infective larvae stages of these filariasis in the dogs. Because the vectors are common. That could be, it could be sometimes an accidental finding. Because when you share the platform with the pet animal, especially somebody is asking. So when you share, naturally that the vector are same, the hosts are same. They need a mammal. So that these emerging infectious diseases have literally no boundaries. That's why there's a word called risk anywhere is see we came to know that foodborne or vector-borne or environment-borne. So this particular panel has been very well formed thanks to Professor Anil Kaul and the team. That I have three members. One is Dr. Sumitra Nair. She is the Joint Director of National Program for Climate Change and Human Health under the Government of Telangana. Welcome, madam. She has got an extensive expertise in public health and climate resilience health program, have been instrumental in advancing Telangana public health response to climate change. She is an advocate of One Health approach, emphasizing the need for collaboration across sectors to mitigate the health impact of environmental changes. So when we talk about the environment, even the previous speaker was telling that when you screen the water sample across stream, from upstream to downstream, we may find different type of bacterial pathogen, which might or might not be contributed by one host. There will be several hosts. In some point, animals may contribute some pathogen. At some point, even wild animals, and some point the human being. So the climate environment is more critical than any other factor. So we need definitely people like panelists like Sita Maya. Welcome, madam. And then I have the second member, Dr. Sunil More. Welcome. So he is a pathologist from Oklahoma State University, and he is working in Oklahoma Animal Disease Diagnostic Laboratory, and he has been working on a lot of viral pathogen and secondary bacterial infections. And he began his academic journey in India from Nagpur as Bachelor of Veterinary Science and Animal Husbandry, and then followed by Masters here in India, and then he did PhD in Biomedical Science in Oklahoma State University. He researched the influenza virus co-signaling pathways during his PhD. He also residency completed in anatomic pathology in University of Florida. So he is a diplomat of American College of Veterinary Pathologists, which is a very prestigious certification in US. And so welcome Dr. More, and he is very much representing the animal health. So we have Dr. Chowdhury from IAPH Hyderabad. Welcome, sir. So he is working as associate professor here in IAPH. He is passionate about teaching and research, and previously he has served in many ICMR, National Institute of Epidemiology, Apollo Institute, and also in CMC Vellore, and also in Government of West Bengal. So his research interests include primary healthcare, infectious disease surveillance, and core epidemiology. So he has got more than 50 publications in national and international journals. He is also editorial board member in PLOS Global Health Journal. So we have a right combination of members representing the climate and environment, the animal health, and the human health. So now I'll let us move the panel. So now I request Dr. Sumitra Nair. Yes, already we are running short of time. I'm just going towards panelist member. So what do you think about the role of the climate change environment? Yeah, this is a most neglected area. I think that in many of these programs, the role of the environment and climate change has not been stressed much. We have been talking about law in animal health and human health. But what are the critical points or critical parameters that you insist upon as an environmentalist or climate specialist?
Thank you, sir. So being from the government side, as well said, everybody were discussing about what to be done, what can be done and all, but especially when a disaster has occurred, when climate change has occurred, maybe it is a floods, maybe it is a heat-related illness, maybe it is an air quality change. So what happens at that time? First of all, the community is closed up, they don't even have contact with others. We also cannot approach over there. So the community itself has to know what is the problem and how to treat that. Because all the information, broadcasting system, everything is stopped, it's halted over there. So then comes what to be done. So we hear the one human health not coming from outside, but from the community, they have to know what to do. Maybe the medical officer over there, maybe the veterinary officer over there, maybe the community, the frontline workers should have the awareness what is happening, what can be done over there, how they have to treat, how they have to come out from there. So for this, I would like to give a better example. Recently, what we had because I am from Telangana, so I will be telling a coding example of my own district, Bhadradri Kottagudem, where we recently had floods. So that pocket, some certain pockets were completely shut down, they couldn't come. So we had the vulnerable population, not the entire population, even vulnerable, where the pregnant ladies, small children, old age people who are taking the diabetic medication, hypertensive medication, everything coming to a halt. So then what we have to do over there? Are we able to go over there? We are talking so much over here. We are not able to go over there. So the awareness comes. I'm very thankful that my commissioner sir himself has gone over there to see over 2 days. He has seen in such a way that maybe through boats or whatever possible, we will try to reach over there. We shifted the vulnerable population from there to the nearby areas, the pregnant ladies who are ready for deliveries, and even the old age people who are literally they can't even move out, the debilitated people taking care of them. But this all happening, when it has happened, we have done that. But what did we do prior? Maybe this setup, this stage should also look into that aspect. What diseases will be emerging when there is a change in the environment? Maybe a high temperature, maybe floods, maybe whatever it is. So this is where the environment system will come into picture. Their help is always required for us, foreseeing what will come in the future, and if at all the disaster has occurred, what best can be done from the community itself. Because at that moment we will not be able to reach over that place also. At least prior, if we know, maybe we can shift them. If all of a sudden it has occurred, what best? So in that aspect, recently we also had an orientation program from Government of India, where from the NPCCH department they have come over. They have given the capacity building to the medical officers and also to the nodal officers. See, we have identified for each district from now onwards, we will have a nodal officer who will be taking care of the NPCCH and also One Health. But of course, because this One Health is a newer domain, we require capacity building to our professionals. And secondly, in this orientation, we have identified the nodal officers and told them what can. First of all, you identify your scenario or your place which is prone for which kind of climatic problem. Because some areas will be having for rivers, so maybe floods is possibility over there. Or there are some places where we have coal mines, so high temperature is a problem for them, where we have more of heat strokes, heat-related illnesses. Or maybe some other place where we have especially the extreme winters, when we have the asthmas and all the air-related illness coming up into picture. So during this time, maybe the climatic variations, definitely the capacity building, not only to the medical officers, but also to the frontline workers. That is, it has to go up to the level of the ASHAs and our agents who are there for the every 5,000 population. So only when we are able to spread this, the prior awareness, yes, then we are ready to take care of any kind of the disaster, any kind of the environmental change. So this is all from my side. Thank you.
I was telling you what is a package of practice? You need a kind of SOP, because it's very difficult to draw an SOP for this kind of climatic changes or environmental, because it varies from place to place. unlike the specific infections like viral borne or bacterial or vector borne, these climatic change or the environmental changes might be very unique. It could be a kind of landslide or it could be a kind of flooding. We have also recorded that, especially we heard about snails. These snails are, small arthropods. So when there is floods, what happens? These snails are literally taken away to far off places, and we have recorded a lot of outbreaks of diseases due to faciora. So this we have seen it in the foothills of Tamil Nadu, where we never see such diseases in animals. How do these occur? Because these snails have been washed away from the Nilgiris and then come down up to the foothills where the Coimbatore is, the other places are located. So we saw that these diseases will never occur here in animals, but the floods have changed the entire scenario of the epidemiology. So that means these kind of climate change environment is very critical, and as you rightly pointed out, we should have a package of practices or a kind of unique SOPs, which is very difficult. We should have action plan, but for which we should have enough data or previous records based on which we can draw, and that would be definitely unique. Thank you, madam. Thank you for the wonderful, substantiation. And Dr. Sunil More. So, what do you think that how this animal health, if we keep the animal health, well, we say animal health is human health, right? But how do we put it into practice? How do you keep it in practice? But animals, you see, you vaccinate. Then what about the other ruminants or farm animals? Or some animals like very domestic, which goes to forest for grazing and come back. So these animals, how do we generally these can be put into practice? Yes.
Thank you. I'll tell you what I do first, and then I'll answer the question.
Yeah.
And so I'm a veterinary pathologist. So my job is to diagnose diseases in animals. So if an animal comes to me, that's a bad news. I look at the biopsy, that means cancer, right? And then another thing that I do is I do postmortem. So when these animals come, like whites and tired, so there are typical diseases that animals get. And so I look at that animal, I open the body and see, okay, this disease is how many seals, active disease, or this is a toxic or something. That's good. But when I start seeing the signalments from the veterinarians that, hey, we have these unexpected deaths on these birds or cows, and we have seen this, right? And so when I open the body of these animals, and if I see a lot of hemorrhagic lesions, that triggers me like, hey, I need to do something beyond normal diseases, right? And so, so I'll give you an example of influenza virus. We have this H5N1 detected in geese. And so in Oklahoma, these are migratory birds that come to Oklahoma during the winters are harsh. But we have a pond in our university, and we saw this over time. And so people, when they see these kind of things, they submit to our necropsy. And so when I did the necropsy on these 4 or 5 birds, I saw a lot of hemorrhages there. And I was wondering, if what are the diseases that can cause hemorrhages? First thing that comes to my mind is a viral disease. And these are wild geese. And so influenza virus was on my radar, and I made a gas application to run a PCR, and it was all being positive. And so that's the first step in diagnosing diseases. And so I'm blanking on your question about how we
Animals clean, but how do you make it in the rest of the farm animals and those animals which goes to forest will come back?
So we do surveillance. We do 2 different types of surveillance. There's active surveillance in animals, where we deliberately go and monitor look for diseases. So we do rabies virus testing in different candidates and different animals. Then we do Western virus testing in mosquitoes. Is that coming up? We do salmonella purulent testing in poultry chickens. And then there's passive surveillance that I talked about, where we look at the animals and see, okay, is this animal fitting the normal diagnostic criteria, or is something different? And so when we talk about these wild animals, I'm actually dealing with one of the cases here. So we have these deers that are used for hunting. Right? And so there are big farms in Oklahoma that you pay and you go hunt it. However, these farmers are experiencing mortalities, especially the newborns, right? Either they're stillborn or they die soon after birth. Now the problem is their moms also die, okay? And so none of the males are dying, only the females and the kids are dying. And so when I'm looking at that problem, I feel like that problem is very unique. It's affecting only one population, right? And so I still don't have answers on that one, but first thing we did is we ruled out all the infections that we want to see in a deer, and so unfortunately it's not there. So those kind of approaches needs to be handled. And in this situation, what happened is they were separating these cases sporadically. Like 1 week we'll get one deer, another week we'll get one deer, and those deers were getting to different pathways. And so it was not a unified approach, right? And so when the clinician did not get an answer, he was curious, like, okay, what am I doing with these deaths? How do I prevent it? So they contacted us, and I said, okay, let me look at all the cases together, right? And so when we sat down together, he and his postdoc and me, that's when we figured out, okay, all these are female, they're pregnant at that time, and all the kids, males are dying. So I think that is a collaborative approach between clinicians and diagnosticians. Does that answer?
Yeah. One more extension of this question for Dr. Bode. Do you think that these findings can be interpreted in One Health, perspective when applying for any human health? Say, for example, you have an outbreak of diseases, which could possibly a zoonotic, right? So, how this can be incorporated in a kind of One Health framework? Do you think that is it possible for incorporating into the existing system, or how it can be incorporated?
So the existing systems are there. So I don't know much about how the system works here, but when we have a disease that we suspect it's a zoonotic disease, or it's a zoonotic disease, we call them a reportable disease. So what that means is we have to inform the health authorities that, hey, this disease is there in this county or this county. And so what they do is after that is they'll monitor the people or animals around that. So I think that can be translated to human population or one of the approach.
Even in India, we have I think two types of surveillance regular monitoring. One is called IDSP. I think now it's called IHIP. Now similarly, we have surveillance system and animals called NADRS, National Animal Disease Reporting System. The problem is many times these as usually goes in silos. Each of the veterinary dispensaries send a report through their district joint director. It goes to the director under the budget, government everything will. Of course, IDSP also I think from primary health center directly goes. But now I think they included many of the zoonotic diseases under this program. But still, there are many spillover events or some infections which are quite new, or new pathogens, or new variants, or new hosts, or new geography. So these are all quite challenges. How these should be incorporated into this, unless we have a single unified framework which can collect all these data from both the animal as well as the human. I think it's very difficult to put them in one perspective. Now I think Dr. Chaudhary has been working on in NIE earlier in ICMR. Definitely he might be very good at epidemiology. And how do you think that infectious diseases can be controlled in humans when there is an outbreak of, we always talk about some influenza outbreak, the avian influenza. So what kind of strategies, one strategies you suggest when there is a disease which are of zoonotic significance or some infectious nature to human? So,
very relevant question. And being an epidemiologist, I have actually worked as a teacher. Maybe while staying at NI, I have also was part of active surveillance as well. So when, based on those angles of when I worked, when I answer to your question, let me take you through something which is little off-bit, not directly related to this, but do you watch cricket, all of you. I think many of us Indians, then when you see, I mean, camera is capturing a video, I mean, looking at from different angles and capturing something. At the end of the day, the decision made by the umpire, by the umpire or somebody else, we all are part. It is not someone who is only taking the decision and we are just accepting. You will see that debate going on whether someone is out or not out. It's a very simple way. When we talk about the surveillance system, taking an example of your last point, surveillance. Surveillance is done for what? Surveillance is done for not just detecting diseases and detecting diseases of whom? IDSP only, as you say, in silos is working, and the other side immediately is also working in silos. Now, that means you are detecting disease, early detection, let's say, and then you are treating. But your question is how we can tackle the disease, or let's say, combat with the disease does not mean that we only treat it. There is other facet of it, how we prevent it, and how we prepare ourselves for detecting the newer diseases that can be both in animal and human, and then we take an action. And in that action, are we involving all stakeholders into our decisions is the question. And there lies my example, that example of cricket, that are we involving the community as well into that decision? I'll take you somewhere else, in this context. If you look at the international borders of India, one side Pakistan, where you have desert, one side Nepal, you have free flow of trans-border population migration for whatever reason. Bangladesh, a huge border and covering many states actually. And then you have maybe illegal migration. You go to the other side, Myanmar, there you have Rohingya issue. And when such kind of migration happens, especially Rohingya and the Myanmar side, you see how the population stays there, and infections does not, of course, it does not matter where border or where something else administrative borders are. And therefore, is our system prepared enough to tackle such kind of situation, whether you talk about IDSP or something else, let's say animal, surveillance system? The answer is possibly no. Ma'am, you gave an example of, let's say, disasters or natural calamities. Such kind of situation, are we also prepared? Possibly no. I will give you an example of IDSP. IDSP is possibly one of the best, have the best potential, but have during the COVID pandemic, that years, no report came. All of a sudden, because I used to look at IDSP, we have analyzed many of different types of data. All of a sudden, I saw that okay, it's full. All 2 years, it is absolutely full now. Where from this data came? So we need to possibly integrate. Integrate means what? Integrate different departments. For example, today we are talking about Nipah virus, the richest and most infectious disease that came out all of a sudden. Emerging disease. Kerala successfully tackled that. But in other parts of the country, are we ready? Do we learn from others? So integration, learning, all such things are possible potential. How do we do that is the question. And to answer that, yes, we have, we in the sense this hall, I think we have enough potential to integrate and develop evidence how we can build upon the system and tackle those situations effectively.
Yeah. So now most of these speakers, if you see that they are only trying to tell how we could manage when there is an outbreak. But I think yes, I think initiated a point where the risk assessment, yes, that is very critical. Yes, now we are talking about now to identify, but how you are going to protect? So that is very critical. Of course, the data like ID has been addressed might give a hint. But what about climate change? Is there any mechanism by which this risk assessment, these kind of temperature or weather or climate or these kind of change in the environment will lead to an infection or an outbreak? Is there any current system, or what do you think that can we learn from the other surveillance and monitoring system which can help us?
Presently it's not there, but Government of India has recently in this month, 24th, we had 2 days of seminars are going on with various departments. They are trying to get a uniform checklist with all these departments for NPCC.
So, but even if you identify the risk, how it can be managed? It definitely needs an original approach. Because if there is a problem in a stream of water or in a sewage which is going out from the city, do you think that only the government, the public health or civic authorities can control? We'll have to see who are contributors. The contributors could be public sewage or an industry or from farm or from agricultural field. So where do we start? Where do you stop? It is very difficult because IIT Madras, they did a study on the Nadaya river. There they have a long river. So they did sampling of the entire river originating from and then passed through the city, end up in the Bay of Bengal. They could find many pathogens of different origin. Some of them are very common in agriculture, some of them in farms, some of them are nosocomial hospital resistant pathogen. So it's really very difficult to manage. In fact, not to manage an outbreak, but how to prevent, how to do this risk assessment. So unless we have an One Health approach, it is very difficult to prevent or manage the emerging infectious disease. Dr. Mori, is there what kind of suggestions you tell to public or to the policy makers, especially when you want to have a regular monitoring of animal farms, or even in countries like India where we have say 400 million cattle, which is widespread across India. It's not like the global north where we have highly concentrated farms. Each farm may have say 50,000 animals or 1 lakh animals. But in India, each farmer has 4 to 5 animals. So you find the entire 400 million completely spread across the nation. So it is very difficult unless you find out the risk assessment and prevent it. This is going to be wider throughout the country, not like other countries where each farm, if you close the farm, the infection may not escape. But here, that's not the case. They are living in the next door.
Disease surveillance and reporting, I think, will be better if we educate the people who are working across the world. I always tell my students, whenever I'm dealing with infectious disease, I tell them, you need to identify patterns of this disease. If they're telling you this is going to be a zoonotic disease, right? And so I really harp on those that in our lab, in our makeup post-mortem floor, all these zoonotic diseases are written in bold and capitals, and it's there, so they cannot miss it, right? And so I feel like once they know that these things are there and they need to look for things, they're better able to communicate. But there's again, we are at tularemia. Tularemia is a disease that Arthur Francis said, right? And so when we see this cat suddenly die without anything to science, that's the first trigger for a veterinarian and for us to look for it. And if they go and do the postmortem in the field or do the postmortem, it's going to expose a variety of people right from the getting into the lab where it's getting discarded. And so that education system needs to make that a point for students to understand. Zoonotic diseases exist and they need to keep an eye on those. One more thing is Dr. Rudra pointed on that one is there's no harm in accepting that there's a disease in my province, my blog, or my district. Otherwise, if we keep hiding these diseases and not reporting those, it's not going to solve any human problems. Those still exist.
Exactly. This is what the DG was telling today morning about the healthy villages. So it is not approaching any problem from top down, but from bottom up. See, like as I told you that example of animal diseases in India, where the animals are, dispersed throughout India in few numbers, scattered. So how do you manage? We have to empower the rural population. We have to empower the farmers. We have to empower the general public. I was even talking about antimicrobial resistance. So AMR is a big problem. Now, how do you manage? All these government rules, policies, regulations will have any effect unless the person who practices, who takes the antibiotic, he himself realizes that I should go to the doctor and get the prescription, get the drug. It's not like going to a medical shop and get the drugs. So similarly, the farmers, the villages, the community has to be empowered to tackle this situation. So One Health, it's not lying only the bureaucrats. One Health has to go deep down to the farmers, the stakeholders. Because most of the programs, the government run programs, I think may not reach properly because the involvement, the participatory involvement of the stakeholders might be lacking. I am not telling that is one reason, but that we should involve the participants. Say there is a program for the villages. Without involving the villages, how do you make the program successful? So I think Dr. Chaudhary, you can tell how do the present system to be modified when this kind of an epidemic occurs, and then how do you make the public or the population to participate? Say for example in COVID, that we all learn. It's a new lesson. We never know how to manage. The government completely locked all the towns. They closed. People were restricted. They were even unable to go out. But this is the first. So we were struggling. So when you have such kind of epidemics, what would you suggest as an example?
Well, sir, let me put it in this way. During epidemic or before epidemic? As I say, IDSP has a tremendous potential and it has over the time, let's say last 10, 15 years almost, is working. And now we are strengthened. IDSP is changed its policy. It is now real-time data capturing. And IHIP gives us that opportunity to understand the data in real-time basis. When we understand that, we also understand which areas are prone to develop what kind of diseases. When we understand that, we actually can prevent those diseases by, yes, of course, empowering the populations about it, empowering media about it. Because I think this is outbreak or health is the, if not the least, emphasized topic or domain for the media, but at least it is ignored. You may or may not like it, but in the hall, whoever it is, you may or may not like it, but that's the fact. And when we understanding that, we also have to understand that government willingness in many places, many states, they have a tendency to suppress. This is a well-known fact. Having said that, now it is lies on the it's a responsibility of the population. And population, when I'm saying it is not about just the community, what do we understand by the community? Is it only those people who are service utilizers? Might not be. The medical officer who is there, the health workers who are working at the grassroots level are also part of the community, and I'm talking about all of them. Do they have willingness to report such kind of incidences? If we know about health system, primary healthcare system, we also understand that the healthcare workers are overburdened. Everywhere, everybody will accept that. My understanding or my experience is they do not report and less reporting. We have to tackle those things as well as we have to think that how we can incentivize them to prevent and to early identify the outbreak and tackle that appropriately, tackle how strengthen the primary healthcare system with adequate drugs. Let's say if we are talking about an infection, when we are talking, let's say that take an example of cholera. I think southern Indian region is since ages we are suffering with cholera, and do simple doxycycline, which is the loading dose is 300 milligram available there, and do our health system know about it? There are capacity building is what I'm targeting, that they know about it, what to do and what stage. So capacity building, and to answer to your question, capacity building and incentivizing about the voting of cases, and finally empowering the community about the diseases. Let them know about what diseases are that they can suffer with and how to report it. I think those are the simple steps that we can do. It's not easy, but this is how we can do it. Top level, it's piggyback the system ideas your IHIP have to openly show how and where the infections are prevailing, so that we can also decide our own how to do it. How to
So I think now it is apparent that to tackle the emerging infectious diseases, it's not just reporting and taking the response, but also we should have a sustainable monitoring and surveillance and other feedback system, which can probably prevent these the later half of the infection. So emerging infectious diseases does not come in a overnight. Of course, few viral infections, but rest of the emerging infectious diseases definitely be identified or risk assessment is done properly. So now it is very clear that unless we involve all the stakeholders, it is very difficult to manage any emerging infectious diseases in the days to come. As we all know that say more than 60% of the infections come from animals, and they say even 70% come from wild animals. We think that wild animals are far away from us. How can they come? It's not so. COVID is just an example of how these viruses can skip post and then enter into the market where we go and take our animals. So this is a very classical example of how infectious disease has to be managed. So the One Health point is very relevant. Unless we work in holistic unison, it is very difficult to manage these kind of situations. So now I request any questions from the audience. Any questions relevant to any aspect of managing this emerging, like using control animal diseases, monitoring of human health, and the monitoring environmental diseases.
Thank you. Wonderful discussion. I have a question to Dr. Sunil Nair. And since it's been part of the government, as somebody who's outside of the government system, it's easy for us to see the flaws, the failures, the problems, and where the government has failed. But being part of the government systems, can you give us this perspective of what are the strengths where the government can enable this One Health? Like Dr. Raghu had mentioned in the previous session that we need this architecture or framework of One Health. What are the unique strengths where the government can play an enabler in establishing or enabling, facilitating this kind of systems? And what do you foresee as the challenges or the barriers from all the limitations to where the government can achieve or cannot achieve some of these goals?
So, from the government aspect, maybe as you have told that, first the awareness in the community is very much such. When I tell my medical officers or my ASHA workers, when they have to go to the meetings, when we have the village health nutrition committee meetings, the sanitation meetings we have, and they have to explain to the people over there regarding any of the diseases, because our aim at the primary health is prevention is better than cure, rather than treating it later on. So for that to make them understand at that level, at the community level, see they can come for the meeting, the problems what we face is, why should we come for the meeting? We have maybe with our design, everything, yes, we have to educate the people, we have to make them, give them awareness, because nowadays, dengue is very much transmitted in the urban area, it has also spread to rural areas, maybe chikungunya is rising, but the awareness to the people when we want to go over there, when we want to, how many people are ready to come over to hear to us? Unless until when they face the problem. Yes, one of their child has been suffering with dengue, they have gone to the hospital for the treatment and everything. When they have seen that the problem, the pain they have undergone, yes, they are able to understand. Maybe the examples of such people who can explain to others Yes, we have to sit together in the community. It is not always the government designing the principles to introduce into the community. In the community, as Dr. Chaudhary has told, it's a demand. The demand from the community should come to us. That comes only when they are aware of it. We are ready with all our principles. We know what to do. If this disease is there, these are the symptoms, this will come. If this undergo all these problems, we are ready to tell from our side. And at the same time, even our ASHA and the ANM workers, as Dr. Chaudhary has told, IDSP, which is our IHIP, we have the syndromic approach. We know how many kinds of fevers are there in the population. We are taking the data of that, so we know, okay, in this area, this is the problem. In this area, maybe this one is the problem. But when we want to go to the community and explain to them, maybe educating them will take some more patience from our side. So this is the problem with child. And secondly, there was one more thing of telling, sometimes what happens is our people are not ready to put the facts outside. It is not at all in that way. That is why our IHIP portal has come, which has given us the lenience. Yes, you report whatever you have seen over there, whatever, something deviations, maybe a rash, maybe fever, whatever, maybe vomitings. That syndromic approach, maybe one area when they are reporting one symptom, the other area is reporting other symptom, we can correlate that symptom and we can counter. In the same way, we are having the diagnostic lab, we are having every district, we have created our Telangana diagnostic centers, depending upon the requirement. For the basic diseases, we have 150 tests we are doing it, but maybe like in COVID season we have. We want a special type of test, we have. So government is always there to stand for whatever new is coming and whatever is there, but it is an understanding from the community side which requires the teamwork of everyone. It is not alone the health department which has to do. It has to come from the animal health, it has to come from the information education, from the reporters side, and from all together where it is revenue people are doing. Only when everybody comes together for our health, that one health of ours will be achieved. That is what I thank you.
Framework, we need a framework which can tackle everyone. So, thank you very much. For now, what of time, I can allow only one quick question. I think as we are getting delayed. So, any more questions from audience? A quick question. I would appreciate any questions from audience.
Not a question, but I would agree that another diagnostics which the government is doing, it's really impressive. The Hubble scope model which the government has set up for public use with 150 parameters, and indeed it's a state-of-art technologies. Digital, the data is collected digitally, sent to the citizens digitally. That's one very unique initiative started by Telangana government running from past 5 years across 33 districts, and I can vouch for that. It's quite unique. Thank you very much.
Sunil and Chaudhary, and actually we had a wonderful discussion about the emerging infectious diseases, how to manage using the workers platform. So this is going to be the only viable and potential option for managing. So unless we work together, unless we unite together, we will fall down for. Thank you so much. Thank you so much, Dr. Their presence here and their contribution. Thank you.
Okay, that was an excellent panel. The second panel for today. We have one more to go, which is the third panel that's coming up. I would like to thank the chair as well as the panelists for their excellent points that were made, and that gives us food for thought, and also we'll be inching towards the actual food in a little while. I request the third panel to please keep it within half an hour because we are really behind time. the third panel now. I'm honored to invite our esteemed chair, Professor Ekambaram, Director of Research, P.V. Narasimha Rao, Telangana Veterinary University, to the stage with discussion. I would request Iyer from IIPH Hyderabad to please give a plant to the chairperson. Thank you. In the meantime, I will introduce the chair. Professor Ekambaram is a prominent figure in veterinary sciences with roots in an agricultural family. He completed his BDSC and AH in 1994 with the highest OGPA and a gold medal, followed by an MSc in animal genetics and breeding in 96 and a PhD from Sri Venkateshwara Veterinary University in 2008. With a 26-year career, Professor Ekambaram has held various roles and is currently serving as the Director of Research at the P.V. Narasimha Rao Telangana Veterinary University. He has contributed significantly to research, completing 16 projects and authoring 60 papers on animal genetics, breeding, and management. A dedicated mentor, he has advised many postgraduate and doctoral students and actively engaged with farmers through 43 TV and radio talks, and has received the State Meritorious Teacher Award in 2019. The chair, please welcome the panelists. The topic is integrating human, animal, and environmental health, challenges and opportunities. Over to you, sir.
So good afternoon, and I thank Director at EHM and esteemed dignitaries and invitees from Oklahoma State University and other speakers, participants from various organizations, from my own university, faculty and doctors, postgraduates, and other university students. And today this is a really good convergence of different stakeholders or professionals. This is, I feel very happy, and thank Director Anil Kaulji for inviting, and particularly Rajan Saab is the first person I met. This is a topic integrating human, animal, environment, health, challenges and opportunities. This is a panel topic we are going to be discussed. Now, for this, the panel members, first I am inviting Professor Rajan Shukla, Dean, Public Health Practice and Community Engagement, Indian Institute of Public Health, Hyderabad. Dr. Shukla has over 30 years of experience spreading over emergency, clinical care, health program management and evaluation, teaching and training, health system strengthening, public health surveillance, designing and implementing integrated health programs for strengthening health systems. He is a medical professional turned public health specialist dedicated towards empowering communities and health systems in adopting new scientific evidence to local contexts, using local resources to address the public health challenges, improve population health outcomes, and promote social development. He works with communities to assess he is a seasoned public health expert, currently associated with UNICEF, with extensive experience in child health and nutrition, disease prevention, and his work at UNICEF focuses on strengthening healthcare systems, especially in underserved regions, to ensure equitable access to health services for all. Is a keen interest in the One Health approach, emphasizing the interconnectedness of human, animal, environmental health to address broader public health challenges. Is a contribution to policy making, health, education, and community-based programs underscores his commitment to sustainable health solutions and a resilient. I welcome his without panelist, Dr. Nirupama. For all sales. She has made significant strides in understanding and improving health outcomes in this demography. Her interest lies in navigating various aspects of public health, including health systems, strengthening, and how the integration between these three components, they are working in different directions. We see from governance, administration, institutional, and at implementation level, and receiver end. Total diverse. As an animal health worker, as a human health worker, as a mental worker or scientist, each and everybody objectives and roles, responsibilities different. If you see at the grass level, everybody can work. All people. Why? Because that is across the wrong emergency here and there. Across the globe, this is emerging, but not detecting. Where developed countries, advanced countries are detecting, diagnosing, preventing, and responding to the risk, but not in poor countries, underdeveloped countries like India, even in developing countries also. There are several reasons. It is a continuous process. We have to live in a given environment. The planet is the same. We cannot expand. The land is the same. Animal has to live, human has to live, plant has to grow. Now, animal and human sharing the same environment. We will study in our course. Environment plays a vital role in development of a genotype, in production of a genotype. If animal is there, unless until cooperate environment, animal may not produce meat, milk, egg, even birds also. So the environment plays a vital role here. If you regulate, if you control, if you keep healthy environment, ecosystem, human is safe. This is mine. We have to focus main on environment, then animal, and only human health in One Health approach. Because why I am telling 60% of pathogen, then what about 40%? If you control and keep healthy, the 60% of pathogens are going to be controlled, prevented. Our food also, safe food you can put. Then other even 70% of emerging diseases are going to be originated from animal, violence. So coming year going to be come from animals, wild animals, reserve animals, generally from environment side. So that's why we have to focus, main emphasis on environmental health. That is, as part of our Prime Minister's recently, as a part of G20 Summit, India presidency, the theme is one planet, one family, one future. It is a, we can take it as a one health spirit. So as a family means at multi-level, multi-stakeholders, multi-institutional, multi-sectoral. We have to keep it as a family. That means we have to unite, just like a family members. Then we can tackle any risk, we can respond any risk. Oh, that's why animal health is a main concern. As part of India, you see our livestock is a dominated in the world is a diversity. Animal, domestic animal biodiversity. We have 212 registered breeds, 53 cattle breeds, 20 buffalo breeds, 44 sheep breeds, 37 goat breeds, 19 chicken. There's a poultry breeds, 13 pig breeds. Just like our states, our different agroclimatic conditions, our culture, we seeing the diversity. Like our animals also brought up in different agroclimatic conditions. So that is the strength of our livestock. By adopting different procedures, some crossbreeding, we lost some diversity and we unnecessarily invited some diseases also. Now the pertaining to environment, we have to focus mainly restoration. Due to pollution, environmental factors, chemical contaminations, heavy metals, and climate change, and loss of habitat, all the stressors, ecosystem stressors, because of intensive farming, livestock farming, agriculture, urbanization, industrialization, human encroach into animals' habitats. These are all causing impacts on disease transmission as well as new disease emergencies. That's why we are getting different diseases. Example, even in livestock also, LSD, livestock, we got better disease. Now present, that is one of the emerging animal disease. Lumpy skin disease, and that is there. Now, with these words, we will start our panel discussion.
Now I request Professor Rajan Shukla to talk about this topic first 2 minutes. Thank you, Professor. So, I was listening to the discussion today, very interesting discussion, very informative.
informative discussion. But the question that kept coming to my mind is, we have all been, there are experts from different domains here, and all have been doing their work. What is, when we talk about One Health, what is something different that we have to do? Is it anything different that we have to do? Or is it we do the same thing but think a bit differently and think with a wider application? Okay, so that is what is, so what One Health is bringing to the table is a thought process and approach, a scientific approach where we not just work in our domain, but think across the effect of our action or our interaction across the domain and on the overall health of the planet and the human health and the animal health. When we talk overall health of the planet, plant health, animal health, and human health all gets included in that. So that is the, so for me, it is like when we talk about yoga, I'll use a synonym. A lot of people think yoga is just exercise, set of exercise. You do some breathing exercises, you do some stretching exercises, and it's yoga. So yoga is a way of life. It is a thought process, your food, your sleep, everything, your interaction, your anger control, everything is part of yoga. So you need to think in a much broader sense of what, how we can work together and how will this happen? This will happen when we start interacting. This was the first platform where we have started interacting. And when we start interacting, we will understand each other's field much better. We will understand how what you are doing or what the veterinary sciences team are doing, what environmentalists are doing, how it will help human health. Similarly, they will also understand what is the requirement in terms of public health or the medical health profession. Similarly, industry will realize what are the diagnostics that are required, what are other support systems, what are other technologies required. Yes, she understands data, but she doesn't understand what type of data are required. That has to come from experts sitting in this room. And then she can work on the data governance, standardization of data, etc., etc. But all this will happen only when we first start thinking in that manner, scientific approach, the comprehensive, holistic scientific approach, and then interacting and applying that across the field. So that is, to me, how we should reach out to One Health. The second thing that I feel, and I've been listening to that right from the morning when DG said, he said community engagement. But if you look at, even we have strengthened our IDSP and IHIP is an excellent upgrade from the previous IDSP. Okay, but where is the community's involvement? Why can't we involve community into surveillance? And that surveillance need not only be for human health, it could be for animal health, it could be for any unusual event. So this is a concept called as event-based surveillance. We primarily rely on indicator-based surveillance, but we should promote event-based surveillance, and that is where again engaging community would be very important. So I will stop because I know there is paucity of time. So I will stop here and yes, back to you. Thank you.
Yeah. Thank you, Jim. First of all, I'd like to congratulate IIPH for organizing this wonderful symposium, and also want to thank Professor Kaul, Dr. Rajan, and Shreya for giving this opportunity for UNICEF to be part of this panel. So to just break the monotony, I'm just using few slides because I prepared it yesterday night. I just want to show it to. So I've seen many of the people are hungry speaking. So I think this will just bring your attention here. And as UNICEF, my priority here is to bring children at the center of the discussion of this entire One Health, and that is what I'll try to make that attempt in next few slides quickly. Healthy Environments for Healthy Children is a new division formed within UNICEF in UNICEF headquarters in New York in 2022 last quarter. So it's just a 2-year-old program for UNICEF. And where this mandate comes for UNICEF comes from this remarkable or a phenomenal resolution passed by UN, which is Convention of Child Rights in 1989, which talk about the child rights that every child has a right for good health, for good food and good nutrition, good learning opportunities, and an environment where there is no child abuse or domestic violence. But along with that, they also say that every child needs clean and safe environment to live. So that is where, as UNICEF flag bearer of child rights, this mandate comes to UNICEF. Otherwise, WHO is the lead UN agency for One Health. So UNICEF did this Children's Climate Risk Index, and it has 2 pillars. It sees the exposure and sees also the vulnerability for climate change in every country. And as per this index, they have categorized the countries. And if you see, India is categorized under extremely high risk. And if you see the total estimation, it's almost approximately 1 billion children who are living in this high risk countries for climate change. To give few numbers, 820 million children are currently exposed. It's not a future estimate. Currently exposed for heat waves. There are almost 600 million children who are exposed for vector-borne diseases globally. And if you see almost 2 billion children, it is almost 90% of the world's child population are exposed to air pollution. Similarly, 850 million children, almost 1/3, 30% of all children in the world have high blood lead levels. I'll come to this point. And children are the most vulnerable because of their physiology, because they are young and vulnerable. Their alveoli are not as mature as adults, so they are more prone for air pollution. They have a permeable blood-brain barrier, so they are more prone for toxic metals and toxic chemicals. So their consumption, their digestive capacity is 3 to 4 times than the adults. So if they have toxic metals like lead poisoning, they can absorb 4 to 5 times higher than, so they are vulnerable. To come to specific impact of climate change, I'll just highlight few points. If you see from extreme heat point of view, stillbirth and preterm birth can increase by 5% with every 1 degree Celsius rise in temperature. Droughts, you know, the impact of malnutrition or droughts on the malnutrition leading to food insecurity and low birth weight. Wildfires, if you see each 1 microgram per cubic meter increment in particulate matter 2.5 emanating from these wildfires is associated with 2.3% increase in child mortality. They estimate that 26% of the under 5 mortality can be reversed. The achievement, whatever we have in SDGs over the last 3 decades, can be reversed if we don't address the climate change risks. Floods and storms, if you see this, infants living in flood-prone area have 8 times higher chance of dying compared to a child who is not living in flood-prone areas. Air pollution, globally, among adults, air pollution is now the 2nd highest risk factor for death after hypertension, that is high blood pressure. Similarly, for children, it is 2nd next to malnutrition. So globally, they estimate that 709,000 children, this under 5 children are directly related to air pollution. And almost 2 billion preterm births are annually attributed because of the air pollution. Ecosystem changes, we are talking about animal health and human health. WHO has documented 10-fold surge in the incidence of dengue. So from 500,000, it is now 5.2 billion dengue cases. And UNICEF categorizes this entire climate change and human health risk factors or the approaches into 5 categories, asking every country to prioritize these interventions on toxic metals, especially the lead, toxic chemicals, especially the pesticides, hazardous waste, particularly biological waste and e-waste, environmental risk, particularly the air pollution, climate change, particularly the extreme weather conditions, the heat stress. The current NPCCHH program from the ministry focuses more only on this and one part of this. But there is a discussions happening at the ministry level, at the NCDC and NPCCHH level, to at least start including lead into the program and then go with the other programs. If you see the risks, the loss of diaries in the under 20 years children, irrespective of the economic status of the country, they are all impacted by air pollution and lead pollution. So no country can say they are immune to the impact of environmental health and climate change. Last two slides, 2 points on bringing the importance of lead poisoning. You saw the global data, 30% of the world's children are impacted with lead. This is the one data from India. NITI Aayog did this study. In 23 states, they found the average blood levels is more than the permissible limits of 5 microgram per deciliter. And if you see our own study, which was done in 10 cities in India, where the KGMC Lucknow was the principal investigator, and Manipal was one of the co-investigators. They did 10 cities. Randomly, they checked the lead levels in blood among school children, and they were all from urban schools. You see, the average was 8.8, far above the permissible limit. And you see, Manipal, 30.6 is the average. The lead levels of blood. One study in Bihar, 90% of children and 80% of pregnant women among their sample size reported the lead levels in the blood higher than the permissible limit of 5 microgram per deciliter. So I will conclude my talk by saying that the children's environmental health deserves highest priority in the world, in every country, in every state. Thank you.
So I am not. We should not use like hyphen words and this. Certificate will take you there. But then there are certain sectors. It was mentioning that a lot of also brings in a lot of infections for that matter, or any new health condition, or any new there's something known as culture in India, and we celebrate all festivals in IPS. Starting from my home, I am bringing some cookies from this day. But in India, in One Health, this is a very less explored area, and this is for an animal. And the absence of that plant or species from the to a health threat, that is true because no before humans that what is going to happen. If animals are fleeing a place, you should flee first. Yes, opportunity, the big thing which is in front of us is social media. We have to talk about social media. We cannot have a conversation of One Health or any health issue for that matter without talking about social media. There's a lot of wrong information being given. We only talk about the negativity of social media. What about the positive? Many of the people in this audience came to know about the symposium because of social media. Social media can be tapped for good things as well. When we're talking about health literacy in a country like India, it is very, very difficult to go house to house and tell people this is One Health, this is what you put a WhatsApp video, it will. So these are the things. There are what I have tried to understand in my other is a very big conversation which is going on not just in India but globally. There are a lot of things. I think this symposium for that one is a place where we can actually make in systems where these data actually talk to each other. 2 days of reading of One Health. I will stop with a quote from Find a New Way to Stand. Thank you.
How to integrate, what are the methods and types of integrations, what is the desired framework, these things before going to this topic. Now I want to give an example, the veterinary profession and medical profession, how they are working in the field. Because if you see, I am quoting on a disease, that is where a disease, anthrax. You know that anthrax is a zoonotic disease. Anthrax is a zoonotic disease, reported disease, regulated, vaccines are available. We know that even medical professions, the doctor working at field level, he knows also. The disease is a zoonotic, it causes, sometimes it leads to mortality, fatal disease. Now what happened in a rural, even now, the disease prevalence is there in Chintapalli, Vizag area, even in Bihar state, Orissa, Chhattisgarh, most of the tribal populated areas, the anthrax disease is there. Because once the disease reported, the animal carcass is going to be consumed by the tribals, where this is a very cheap source of animal protein. Thereby, they are infected. Now, some of the endemic areas, those are every year, at least there's a rotation basis, the disease is going to be recorded. Veterinary doctor immediately will go and see the case and treat the healthy animals, quarantine, isolation, and preventive measure, vaccine for other healthy animals. And he will report to, after few days later, the health person will go and see there is a disease symptoms in that population. He will go and record and give the treatment, and in government hospital he will record and send the report. Next year it is going to be again on rotation basis, repeated. Once the kind of disease, declared as an endemic, you have to put surveillance. Every year we have to record data and share the data between medical department and veterinary department. At least that village level, the veterinary professionals and medical professionals has to share. But the system is not like that. The people, that's why siloed systems, top to bottom. The system is like that. Under One Health approach, how to integrate human, very important. And this is a given situation. What kind of approach or framework is desired under this condition?
We need to establish collaboration, coordination, information sharing, but for what purpose? The idea should be for how to look at actionable points at all across all stakeholders. So actionable points for researchers, actionable points for community, actionable points for veterinarians, actionable points for pharmacists. So if we start developing a data sharing platform and analyzing that data into actionable points for different stakeholders, I think that will be one way of giving back to various stakeholders and will get a greater buy-in from them. If you get back something, you always feel like contributing. If you don't get back everything from what you're doing, then you don't, it's not sustainable. So that is one thing that I would, we will be looking at the dictionary. So silos exist everywhere because the way, as we grow into education, as we go into higher education, we know more and more about less and less. That's what an expert is. An expert is a person who knows more about less and less. Okay, so that's how this. Now we have to challenge that thinking. Challenge that thinking, and we have to work with different stakeholders, within the sector and across the sector. There are silos within the sector, and of course there are silos across the sector. And we need to work on those, and we need to break up the way you work together. Okay. So I think that is what is important. I'm not going into nitty-gritties and details of integration, but I think the start is here, sitting together, talking, identifying few action points, few things on which you can work. One Health is huge. You cannot work on everything. Start with few action points, maybe antimicrobial resistance. I know it's not easy. Maybe food security, and across the point.
That one thing which I want to emphasize is the concept of the integration what we are talking at the community level. When we say CPHC, it is not a primary health center, it is the primary health care. Health is a misnomer because it doesn't get, if there's a heat wave, if the case medical officer is not equipped to treat that patient, so then your surgical delivery fails. So surgical delivery is very important component of the comprehensive primary health care. But other two important components which we are talking is the multi-sectoral coordination. So all your stakeholders, whoever are there related to One Health, within that comprehensive primary health care area, what we create. Third strong pillar is the community, which we are talking since, be it localization of SDGs, be it a healthy village concept. Everywhere there's the community demand generation, community participation, community engagement, and community accountability. There's no accountability of community until now. We know how to demand that is coming up recently, but their accountability is totally out from there. So if you can strengthen the comprehensive primary health care, that can answer the integration for One Health. And the approach for strengthening should be the systems approach. Be it the financing, be it the leadership, be it the MIS, the mechanism, wherever it is, be it the logistics, whatever it is. So I think I rush my point with this comprehensive primary health care approach.
So to answer sir on how can we integrate, what I have seen in the field or any kind of group activity that we do is that there needs to be clear job descriptions. We have clear job descriptions. I work on public health, you work on veterinary, you work on pharmaceutical. So if we want to integrate everyone for One Health, there should be someone with a job description which says integrate everyone for One Health. That is very important. Otherwise, no integration ever works. You can take any group event, there's always a leader. A visionary leader is important for any group activity to be successful. And that is what I have seen in my work in the community or as a teacher. If I do group discussions and tell them to submit an assignment, it never comes. But in the group, if I tell them that you are responsible to give me the assignment, it comes. So I think that is the solution that we should look at, sir, that we should have one person or a department whose job description says you have to integrate all these sectors for One Health. Thank you.
Yes, this setup is very clear. Now, from the top side, from the government of India side, it is they are making from ministry level, Ministry of Health and Family Welfare, Ministry of Forest, Ministry of Animal Husbandry. and Dairy, and Ministry of Commerce, and other departments, they integrated a top at governance. Then next level, the officials level, coordination committee, that's the 4 C's, early was collaboration, coordination, communication, and capacity building. It has started from that level. And Government of India also, they started One Health institution at Nagpur, and also other, like in animal health side also. Several programs they undertake. Recently, Brucella eradication control program also they started. First time, no, other this R&D, research and development. ICL in sharing and funding. This level, at implementing level, I told you that at village level, what kind of approach? So medical department, animal husbandry department must have to share data, information, that is surveillance and reporting information, you have to share and respond positively. Then we can deliver and reach the one approach, goals and objectives. Now, with these words I'm closing, and I invite only one question. Already we are on shortage of time for our discussion. Anyone can raise? One question.
Very good question, and a very serious problem which is not talked about. I think the solution will come with initial we start talking about it. In India, we are still not even talking about it. Recently, I will tell you one study which they did in Bangalore city. And in the Bangalore city, they collected samples from all green leaf vegetables from every site in Bangalore, be it in your DMart or be it in your street vendor or everywhere. Every chicken has shown positive for lead, has shown positive for high iron. They are telling that iron deficiency, but these are with high iron unacceptable levels. And one of the reasons they found was the heat. Now, there's no evidence. So if you want to address, we want to identify these children, we need to generate those evidence. I think the academic institution where we are here, our first job is to have, without evidence, government will not accept it. Even when we are talking about lead high levels, NITI did not accept it. They went and did their own study. And then they came here. We need to start generating those evidence for e-waste. And again, it depends on economy. What Dr. Professor was telling from Oakland University, that it is all about economy. So it generates huge economy for the country, and it is not that overnight you can change it. But community, voices from the children, voices from the youth, social media, we need to pressurize the government to take decisions for them. Thank you.
Almost 6 years for tobacco industry to accept that. So I think that's the power of social media today. The perception became negative. Okay. Till before that it was all advertisement and they were beating it with advertisement. So when the perception started becoming negative in tobacco industry, so I think that is when we have to evidence and build your perception based on evidence and hit it hard, and then the policy and the sector will follow.
Thank you, sir.
Now is with this panel discussion, we covered very important aspect, healthy and safe. We have to give that healthy and safe environment to the children. That is a right of to the children, of the future generations. Because in One Health aspect, it's highly vulnerable. That is, 1 in 3 is died with foodborne diseases. That also is there. There is a foodborne disease. Now here, sir has highlighted good aspects due to climate change, how the children are suffering. And also there is new aspects, tourism and migration spots. Human beings also, these things has to be included in One Health aspect. It is also is very important. Now it is from an international level, tourism, people are moving across the globe. This is also very important. And overall, unless until we provide healthy and safe, healthy environment, ecosystem to the animals, then only it is possible to human beings so all become free from emerging diseases. Then we have to safeguard, restore the environment health at the same time also. That is our responsibility to safeguard the environment. Then it is going to be achieved One Health approach. Thank you.
Thank you all for that excellent panel. I have the unenviable job of asking people to stick to time. So I'm going back and forth and disturbing the panel and the chair, panelists and the chair. But that's so that we keep. I have some housekeeping rules. First of all, thank you so much for that panel and the chair as well as the panelists. And also to UNICEF for breaking the monotony, and that was a welcome change for the short PPT. So the housekeeping points are that we will break for lunch and we'll keep it as short as possible, if possible within 20 to 25 minutes, please. I request that the students be guided, students from IITH as well as students who have come from out. Because there is lunch which is here as well as in the other place because of shortage of space in the room here. So please follow Madhvi. I also request Professor Anil Paul to present a memento to our chairs and to the external panelists. And I would like to call upon the stage the panelists, and I'll just, in any order, I'll just lift. Professor Malaya, Professor Professor Rudra Gowda, Professor Raman Muruswamy, Professor Sunil, Professor Pitambaram. And Dr. Sridhar Prasad. Thank you, Dr. Paul. I now request everyone to please join us for lunch, and we will have the mementos for the speakers and the panelists post lunch. Also, we will have a session on that. So please join us for lunch, and please be back in 25 minutes or so. Thank you. Okay, there's a small change in plan. Please proceed for lunch, those who want to. I also request the internal faculty of IITH Hyderabad to please come on board now itself near the stage. We thought we will have it post lunch along with the rest of the panelists after lunch, but we will do it before lunch. Thank you.
followed in food security. You have, of different shapes and different colors. You have had round revolution for potatoes, yellow revolution for oil seeds, golden fiber for jute, and then golden for meat. Complex issues around exploitation, unhindered exploitation of all these, the pursuit of putting humans in center, very anthropocentric design of this so-called development, is something which one has to really critically look at in the context of One Health. How do we locate us as human beings, and we assume that everything around is for us to consume and beyond and try and see what is it beyond these evident exploitative way of looking at other living beings, including plants and animals. So that's a context. And if you come back to Indian context, food security is highly vulnerable because we largely depended on few species, either animals or plants. We have moved away from indigenous crops, indigenous animals. I was talking about the native breeds of cattle and poultry. We moved on in the pursuit of exponential growth to large-scale monocropping and large-scale, output, for example, poultry. So if you try and look at all these things and these revolutions are slowly plateauing, and suddenly COVID happened. And then things all changed for us. Yes or no? Okay, thank you. I just trying to keep you awake. Lunch was very sumptuous and tasty. So when you look at these, we suddenly started realizing that, okay, we have to connect the dots, humans, animals, environments, and plants, and then we started to talk about animal health, plant health, lesser in scale, but environment health is slightly bigger. If you look at the silos, what we're talking, Nilpama made them famous now. So when we have these definitions, and if you look at One Health as a collaborative, multi-sectoral, transdisciplinary, and holistic, and that's where I think Professor Malayar's talk this morning was very interesting, and he was very happy and glad to be here today because somebody spoke about social sciences. And being an anthropologist, it touches someone. So he's glad that people talk about social sciences because ultimately that is what it is essential. Solutions are there, but are people? Is there an uptake of solutions? Is there uptake of whatever we as specialists are talking? Are they reaching? Is the concern. So that is where it brings to exciting sort of a panel. We have wonderful speakers, friends, part of speakers. Professor Ekamaram Garu is very low. Yeah, the mask on. So that brings us to the point where I wanted to connect is that all these panel speakers are experts in their own domain. We have heard Dr. Ekamaram Garu. It doesn't need much further introduction, but he's there representing the animal health. We have Dr. Gauri, cognitive scientist and behavioral scientist, who has been working on issues around human health, but from a behavioral sciences perspective. And we have Dr. J.K. Lakshmi, who is an ardent, holistic health proponent, and her core strength has been health promotion. So I won't wait much time. We all know each other here by now. So I would start with a sort of a discussion to try and set stage to invite Dr. Ekamaram sir to try and talk about the issues about food security and food safety. And one point I might want you to talk about is somebody talked about chickens in the morning. I think sir spoke about chicken. And I think that's one of the fastest growing sector in among the animal protein industry in Indian context. The pink revolution and the silver revolution coalesce in trying to make poultry as an important sort of an industry. And Telangana and erstwhile Andhra was known to be egg bowl of India. So in that context, sir, I would really want your inputs to begin with on why do we think to be cautious when we are talking about animal protein in the context of poultry. And we know that growth promoters are also was talking in the morning. Quercetin is very commonly used, high-end antibiotics to promote growth. So we'll begin with your thoughts on that, sir. And also the subsequent question would be in terms of how do we integrate ideas of, because you're also heading research, how the research happening in veterinary science could be translated to the common people. And again, take on from what Dilpama said, how do we please look at me also, sir. Not on the phone. So I was trying to bring her attention in terms of how do you translate these messages to people who are dependent on the poultry industry to as their livelihoods and for security or food safety and security. We'll start with.
Good afternoon. Now, this is a good question. And poultry industry is providing livelihood in rural area. Earlier, poultry is small and marginal farmers and small villages also is there. The production system is totally changed now. It is total corporate tax. Even in rural area, poultry farms also is in the hands of 2-3 players. Kadeshwara, Suguna, and other units of total industry. Right from breeding to and processing and delivery of end products. Sector is segmented like that and total in the hands of the system is integrated type. The poultry industry total. These 3 players, they supply the chick, they supply the feed, they supply the meat, supply the services, and they buy back the birds as per their market price. The owner has to provide only shelter and produce. This is the system is going on. Now see why the AP state and now even Telangana, this state is called as egg basket of India. The poultry, father of Indian poultry industry, D.V. Rao, Venkateshwar Act. Also upon he was a worker and of our university. The poultry department here in College of Veterinary Science, Hyderabad, there is a main center for this development and changes. Now see, one is the egg, another is the chicken, meat production. Earlier the meat, the egg production, just we want to understand how pressure is building on poultry production. That is intensive farming. Ultra farming also is there. Modernized, totally on par with developed countries. The poultry sector. Now there is a lot of pressure. That's why avian influenza, emerging diseases are coming from poultry side. Why it is coming? Because we have only few varieties. We have now, as of now, in India, 19 registered poultry breeds as per the National Bureau of Environmental and Resources. There are different agroclimatic conditions and different native birds are there. That is an integral part of our lifestyle as a backyard poultry. That was the traditional system and scavenging system. Zero input and producing free eggs and meat. That's a tasty flavored meat That was the system also. Because of what happened on commercial and business scale, we got imported white leg corn and produced, developed and egg production once upon 180, 200 eggs. Now today, 328 to 333 eggs they are producing. The capacity has increased by means of different breeding methods, selective breeding, cross breeding, different ways and means the system has developed by means of research R&D in the animal feed, in the animal poultry breeding and poultry health also. Because different varieties also developed under broiler system, private industries. This 333 egg means there is a biological limit. Still, people are working how to increase it. Now it is a plateau. Then what else? Egg cost has increased. Earlier 1 rupee egg. Now it is 6 rupees, 8 rupees. In some seasonal variation also is there. Keeping quality. Now how to overcome that, reduce the cost, marketplace, reduce the feed cost. How to reduce the feed cost? In any livestock farm sector, the cost of economics, the main determinant is the feed cost. 60 to 65%. Now the broiler bird, how to get that body weight? By growth promoters, by years back. So antibiotics also level there. Added the feed additive, they increase the body weight 0.4 to 1.7 kg feed. That's the FCR, feed conversion ratio. For 1 kg of chicken production, the body is consuming 1.4 to 1.7 kg feed. Now, present broiler chicken rate is 220 rupees case. That's a decimal. And live weight is 160 rupees, 150 rupees. There is a seasonal variation is there. On sometimes 90 rupees. During COVID period, 1 rupee, 1 bird. There is several things due to avian influenza. Now that's why there is there. How to overcome that one? Because the system is intensive system. Now almost biological limit we reach. As of India now, 530 plus millions of commercial chicken is, and 300 plus millions of backyard poultry also is there. Because the trend is changing. People are coming, preferring desi birds. That's why universities have developed their own varieties. Country to thrive on zero input and scavenging system. In that line, our university has developed our largestly dual-purpose poultry variety backyard and can able to produce 160 to 180 eggs and up to 1.8 kg body weight. This is suitable for zero input, that is a scavenging system. Under backyard system. Alternative. People are going for desi chicken. Pressure, what happens? New diseases, the migrator bird effect, and within the population, vulnerability, high susceptibility increase, and because of that reason, the H5N1 avian influenza.
Pause there, I'll come back to you. Yeah, that's an interesting and quite a comprehensive overview on the poultry industry, because That's one of the, most popularly touted response to food security, especially in terms of protein security for the large masses. We have problems. I'll come back to what he said.
One point.
Yes.
Now here another thing, for as a healthy person, ICMR recommended 180 eggs per year. Now as of now, India is producing 138 billion eggs. The per capita availability only 101 eggs per year per capita. There is a huge gap, 180 to 101 eggs. There is still lot of demand is there. And the same meat also, 9.7 million tons of meat we are producing. The per capita is only 7 kgs per year. 7 kgs per year. But the recommended ICMR recommended is 11 kgs. There is a lot of gap between recommended and per capita consumption. That's why the demand is there.
Now I would call upon Dr. Gauri. Knowing your work around COVID, and also in terms of your research on vaccine hesitancy among rural populations and also in terms of the rural populations and healthcare professionals. I'd like to link, if you can, to try and see, can we connect vaccine hesitancy among the humans and vaccine hesitancy among the people who are raising livestock? That is one question to begin with, because I think that's where a lot of One Health issues can be looked at. Prevention, the prevention perspective. How do we integrate the research and development around human and animal vaccines? Is there a way to connect these two sectors and silos again to continue?
Thank you, Nandu. Yeah, I actually echo Dr. Lokeshwari that feel like a fish out of water is the thing where I come from a very behavioral human health perspective. So thank you for linking it to my work. I think one of the things we can kind of take across this animal health, human health, is it's humans making the decisions across both sectors, and the drivers, they're both market drivers for vaccination and animal health, social and behavioral drivers across both for human vaccination and animal vaccination. There are some commonalities that I could probably touch upon, and some I might ask for clarification because I'm not familiar with the coverage of animal vaccination in India. Is it considered good at this point, or is it before I continue on? I just wanted a clarification of what is the current animal vaccination coverage.
Coverage is there. The disease surveillance and reporting and preventive measures are there. But the coverage for certain diseases, especially the FN, foot and mouth disease, hemorrhagic septicemia, and in case of the sheep and goat, heterotaxemia, and now recently that is gluten disease that also newly introduced vaccination. But the coverage is there as per this total vaccination being done by Government of India first and state government through the department is there. Yeah, but that is there nearly, I think 60 to 70% population will cover because there is sometimes farmers and between the gap because of non-availability and bringing of the animals to the site of vaccination. There's a logistical arrangements and the.
Thank you for the clarification because I think that's the gap in my knowledge is I don't know the animal vaccination coverage. So I think when we talk about some of the behavioral drivers that impact animal vaccination, I think as Dr. Ikambaram has also highlighted,
It is the cost, the accessibility, and I think there is probably one variable which probably is unique to livestock and animal health. Probably the commercial value of the livestock probably drives the vaccination coverage in animal health, which may not be the case which is there for human vaccination. And of course, knowledge and use. I think there were some studies that I was looking at when we were looking at livestock. There is, I think Dr. Rajan also touched upon it, the diffusion of innovation or dissemination of knowledge transfer from experts to farmers is actually, the gap is huge. And that's where I think people from public health, animal health, social scientists can actually have a role to play of knowledge dissemination and improving the education and awareness of bridging this gap where the scientists seem to know the importance of vaccination. The scientists understand, I think, across different livestock, whether it is large cattle versus poultry, from both from an economic sustainability, environmental sustainability, and even a social sustainability point of view. Why vaccination is important? But I think that gap probably persists for a bunch of these reasons about risk perception and cost and the commercial value. But one of the things I wanted to touch upon, and I think Nandu in his introduction talked about, I mean Shailaja mentioned, we have also lost touch. Indigenous knowledge systems actually do respect this overuse of natural resources and know how to draw limits. And I think if you look at the US Native American population, or here also in India, we kind of, with the Western modern understanding of siloed approaches of specialization to sciences, this respecting boundaries of limits of how much to use and consume and how much to limit is, I think, one of the critical factors that has to change in our understanding and approach to how we, reaching the goals of One Health and sustainability.
Yeah, I think that actually touches upon and segues into my next question to Dr. JK. JK, since I know many years, has been an ardent environmental, sensitive, conscious, and also wants to promote environmental holistic outlook towards, health. And her specialization and doctoral training is on health promotion. So I want to bring, taking on from what Gauri and Dr. Gauri mentioned, now I think it looks like we are secure in terms of food. Though there are certain gaps, but looks like we are secure. So, in a way, then how do you reconcile the existing, approaches towards human health, animal health, plant health? Do you have some sort of a overarching sort of a perspective on that? And also, to continue that, would you also comment on the food safety aspect of it? Now that we are secure, now we are talking about meat being contaminated, meat being contaminated. TV did not have enough meat, they never complained. So I'm trying to look at it that way. Do we have enough now? We are complaining what is it lead or copper or gold? If you say gold, everybody will be vegetables. So we begin with that.
Yeah, thank you. I'll speak a little bit about health promotion, my favorite topic. If you don't me out of sleep, I would be saying the same things. So, two messages from just the term health promotion and the term One Health. There are two calls to action or two positive messages and two cautions that I get. And one message is one of holism, of the imperative to take a holistic view of health. I'll talk a little bit more about that. And the other is to take a life course approach. So health is in the first place not to be narrowly conceptualized as absence of disease. There's much more to it. There are many positive aspects to it, not just an absence of something negative. And the life course approach, because it's not like a one-shot thing. Okay, you're healthy, not healthy, like all done. There are consequences, there are actions and consequences, short term, medium term, long term, and this also offers us the opportunity for intervention. So there are ways that you can reverse, repair, restore to some extent what is gone wrong. So those were the two positive messages. one that, again, related to the message of health promotion, that we should not give in to the temptation of medicalizing health. There are some medical aspects to health, but there are only some medical aspects to health. The rest of health is a matter of good functioning and well-being and just living life. So we should avoid medicalizing too much and coming up with medical solutions and these really sledgehammer-like solutions to things that don't need them. And the other caution that I'm thinking about is that we should avoid getting so enamored. I mean, we shouldn't be following trends so blindly that we dismiss again the thing that everyone has spoken about, but I will continue to speak about because I feel so strongly about it. We need to examine all practices. Just because something is traditional doesn't mean it's useless or primitive or regressive. There is value in many other practices and there's value in many new practices. So we should be wary of dismissing wholesale either old or new practices and pick and choose better. About food, as you said, food security is a big concern and food safety. That's in the title of the panel, so we can't avoid talking about those. But I want to add one more S to this food S. And the S that I want to add is food sovereignty. That is the ability to have a preference and to exercise a preference on the foods that you consume. And that also, as you can see, makes it important for the powers that be to make things available, to make things affordable, to make things accessible. So with food security, I mean, our concerns with food in order would be first quantity. You need enough food. And to translate it into nutrition terms, it might be calories. And there, I think we do have enough. When I say we, I mean in the aggregate. There are still people who are literally going hungry, and then there are people who are what is called hidden hunger. So they may not be missing calories, but they are missing nutrients. So we do have enough overall. Let me use the terms or the words that no less than Gandhiji used. We have enough for every man's need, not for every man's greed. So we do have enough. And when I say man, of course, I'm hoping that man embraces all of humankind. Okay, so quantity, calories, and the next step is composition. So you have to have the nutrients that you require. We are not as self-sufficient as we should be in that regard, but we are there, and people who have the means and the agency also have some kind of good grip on composition. But there's more. There's ensuring absorption. I mean, how these nutrients or these food items are put together, made available, consumed, and so on. So there are many gaps in those places. And then safety, which you asked me to talk about. So food is not always safe. And here again, I'm going to come back to One Health. The world has become smaller in many ways, but it continues to be its size and larger in many other ways. What I mean is we have excellent communication systems, and we know the trend that is taking place at our antipode immediately, and we are keen to jump on the bandwagon of consuming quinoa and consuming chia seeds and those kinds of things, which may be nutrient, I mean, there's no confusion about that. But for quinoa to reach here and come into my plate, it's very, very expensive. It's very expensive in ecological terms and for many dangers that many speakers spoke about in the morning. And I'm thinking we are giving plants to our guests. And the guests will take these plants, and the international guests will not be able to take these plants, which is a good thing. Because with these plants, there are some free gifts, as we call it, that we're giving those guests, and we're giving them a few pests, and we're giving them quite a few other things along with these, which have. Yeah, so we've done that. So we are free to move these pests and invasive species around here, but at least they will not. So we need to think about many of those things. Infections we talked about already pre-lunch, but also other kinds of conditions that are not infections. And they have also been talked about. There's lead, and there are all those contaminants of different kinds. And as Professor Ekaman talked about, there is. Actually, I'm confusing the various veterinary experts. But you spoke about hormones and antibiotics and so on in the. So there are many foods that are giving us various other things. So I may develop a hormonal disorder or just experience all kinds of untold stress. and it is actually related to an animal food. I might be consuming honey, which I don't even think of as an animal food. But there are many such things. So there are infections and non-infectious contaminant kinds of things that come in, biological and chemical contaminants. And this safety has a lot to do with the travel that the food has to make. So I think that some ways for us to keep ourselves a little safer will be to be slightly old-fashioned, but not terribly old-fashioned. Because if we really become extremely old-fashioned, we have no agriculture either. Then we are completely at sea. So we need to be somewhat old-fashioned and be local, be organic, those kinds of things, because we have solutions. We have the most efficient solutions with us. And if we don't have to look outside for extremely strong chemicals that will wipe out what we don't want as well as what we want. So we have many solutions of that kind that we need to be looking for. So local, organic, minimally processed, those are the ways to go to achieve this kind of health promotion. I do want to say that animals and plants are the living world. You spoke about how we have an anthropocentric view. We definitely do. And we need to school ourselves into far more humility than we currently possess.
I'll stop you there. It's hard to stop. Quite passionate about it.
I'm sure Sharaja was waving madly at me when I was looking.
So that was wonderful, JK. You know, that actually connects what we talked about. Trying to talk about food security and connecting, taking it forward. But are we really food security is a question you raised, and that's I think for us all to ponder in terms of how inequitable food security is. And also, Dr. Ekamaran also emphasized the fact that there is still gap, though we made leaps and bounds of progress in terms of the quantum of the food safety efforts, but we still are falling short, and unfortunately is inequitable. And Gauri has highlighted the ways to try and think. So on that point, I was trying to also connect and leave the last words to Dr. Ekamaran to try and see how we are here. In the morning we were talking that this is a One Health day. This day has plant, animal, human health, and rural development institute all together. So how do you think then is for us to come together and collaborate? Does the existing structures facilitate these cross learning and cross sharing? And also, should there be a sort of a research and development where we all come together? Would IFH be a venue, or would Narasimha Rao Institute for those things? So where do we really go on from here is my question to people to look at it.
Yeah, it is collaboration. That's the main principle of One Health. That is through 4Cs morning discussed. Now, in this here, in my view, this is a main challenge at different levels because multi-institutional, multi-sectoral, multi-stakeholder, at multi-level means different administrative governance, mindsets, traditions, culture, practices of that. So here, in my view, the main challenge is morning as I discussed, that is a silo system. That's we are working isolatedly. That is main. We have to reorient, reorganize our system, the existing. That's the first one. The second one, limited resources, limits of our resources. One is for funding gap, insufficient budget availability for different institutions, and also shortage of staff, professional staff. I am talking about. For example, For veterinary, India having 532 millions of livestock in the world, 302 millions bovines, 144 millions of goats, and 74 millions of sheep are there. For doctors ratio, as per the Veterinary Council of India, regulatory body, nearly 5,000 animals in livestock units, one doctor must be there. But in India, we are getting only total 67,000 plus doctors are there. Here is our population varies. And like that, only 56 veterinary colleges and 706 medical colleges are there, even in medical. Nowadays, this year, more number of colleges have started, medical colleges. See, that is other. The third factor, the regulatory and policy support, it is not sufficient. The existing regulatory system has to be reoriented in the One Health aspect and this convergence and collaboration perspective. We have to, the existing system has to be changed. The fourth point, the cultural and practices. Morning discussion, community fragmentation of the policies and the community engagement that is there. The existing old traditional practices, sometimes it is a conflict between One Health and old system in the villages. That also is we have to overcome. There are main challenges, and if we overcome these, it is possible at government level, institutional level, at grassroots level, the people working with the animals, humans, and plants. Even soil is.
Oh, wonderful, sir. That actually connects what we all wanted to do since morning. Resources, reorganizing resources, looking for more funding for research. Dr. Velo was talking about in the lunch how difficult certain ideas, even in the West, how really want to bring to the table about talking about these, getting these silos together. Is it possible? I think it's still a long way to go, but we still, I think it's a beginning to start talking about realignment, policy level, a sort of a regulation, support, and finally, in terms of the cultural practices, being an anthropologist, been working in the area of public health and also One Health. So I'm trying to push something called multi-species ethnography in anthropology. I'm just bragging about myself, but also selling the idea that we can bring in the ideas of One Health in all the disciplines we try and talk about. Dr. Acharya who is here, is heading the management. Can we bring about these ideas about One Health into all of our disciplines when we go back, and then try and see, can we cut across these silos, so-called silos, and try and collaborate? Because I started that way, and then I'm trying to push my existing boundaries to try and continue the conversations around this, and it's time for us to think about the going beyond the anthropocentric framing of sustainability. Let us talk about multi-species justice, multi-species sustainability, rather than thinking of us and ask the students first to start off with some questions. If you're not asking questions, we're not stepping down. So, Sarah, madam, it's for you, Ness. Yes. Yeah.
So my question is Dr. Martin. So this is something that I see almost every day on my way home. Is that small cat owners who have around 5-6 cows, smaller number of cows in that. So they use the cows to graze wherever they can in the area. And these cows end up eating plastic over grass. Even though there is grass available on the other side, they prefer going to the plastic dumps and eating plastic. So my question, and two is how safe is the milk from these cows that we plastic and we make for our houses for consumption? So you guys
Just before that, ask, as trans plastic is also very tasty.
See, here, one of the farmers in India, small and marginal farmers, the livestock is just like main livelihood. In your case, if so, it is not whether it is giving milk, it is not desired. There you will find it is a normal condition. Certain signs, and that is float hospital open. But overall, the milk and other aspect it is not. The healthy food is good for health. That's why
Animal experts here the same thing, so why not? So this is actually a question. Dominant literature or evidence in the Indian context is the majority of livestock. That's one. Secondly, in vaccination, this is a very nice question. Can fish be vaccinated? Would that be possible? Yeah. How?
In the water, they say.
Oh, you drop it in the water.
Blue revolution was.
see here, there's antibiotic, and what happened at a national level, NDLM, National Digital Livestock Mission was started. National Digital Livestock Mission. That is, they are also maintaining real-time data of animal health, vaccination program, preventive measures, and animal traceability also is there now. That is very important. If anything happened in remote area, a particular category of animal, that was also vaccinated, unvaccinated, as per the owner, unique number is there. That is there where they are identifying and tracing. So system is there. Even State Department of Animal Husbandry, they are maintaining records at village level. How many animals are there? Who are the owners? How many animals they have vaccinated? Now the system is they have to upload online immediately that vaccination. Yeah. Antibiotic use also, AMR also. The highest percentage of drug is used for to control mastitis disease in India. There is a problem in India. Mastitis they are using. Then followed by reproductive disorders. There are multiple mastitis and a lot of variation is there. That's why now is there. The other antibiotics in poultry that is there. But that work is going on. Even the research institute, even our faculty is there. Yes, and some herbal products and those things also there.
No, please.
Veterinary safe now.
As you reduce.
There's no difference. Cost of veterinary medicine is higher than even as I prefer to buy a tetracycline or even for various even box of the human practice. Sheer volume. Firstly, the vaccination, there is no control of user by side. And there, like you pointed out, there are certain livestock diseases which are economically important. Like yes, once the waters are affected, animal doesn't drink milk. That's it. So, as the something in feed, there is sometimes more so in commercial. Whatever animal today will bring for commercial, The use of antibiotics directly or indirectly. The use of antibiotics directly or indirectly.
One more thing, in animal sector, breeding system also is developing for breeding with animal disease resistance. There's also a lot of research in small ruminants and the disease there. The animals which are resistant to particular diseases, parasitic disease. So that kind of thing is there. And that is one of the.
Sorry. Yeah. So just to conclude, I think, hope we didn't scare you of eating eggs, chicken, and meat. So I think, yeah. So I think that the point is, I think what Dr. Ekam was emphasizing in terms of creating platforms for all of us to collectively think and then eventually bring community on board for taking forward the conversations around One Health. And I think probably having a representation of plant health probably also should be part of this time. I think that's one gap we what we thought. I think thank you, the panel, for wonderful conversations. That's one gap we what we thought. I think thank you, the panel, for wonderful conversations. And
Thank you to the chair. Realize compliance just goes so fast. So we will now move on to the next part of the program, but before we do, I would like to introduce our very special guest here, Ajay Sami sir. I'll just do a 1 minute introduction because we have a more detailed introduction coming up later. Ajay Sani sir was the Secretary, Ministry of Electronics and Information Technology, Government of India. He being a very illustrious IAS officer. He was also Principal Secretary, Health, Medical and Family Welfare in the Government of Andhra Pradesh earlier. I will talk more about sir once this particular panel also gets over, because we'll have a more formal introduction to him. But thank you so much for joining us here. We are really, really honored to have you here. Thank you. Now we're moving on to the penultimate panel discussion for this event. And the panel is on anti-challenge requiring. I'd like to request the chair and invite him, Professor Anil Paul, Director, IFH Hyderabad, to please chair this panel. Dr. Anil Paul, and you know him a lot, first public health professional, working in the field of infectious diseases and women's health for more than 35 years. More recently, he served as a clinical professor and program director for global health at the Oklahoma State University, where he also directed the high complexity infectious diseases lab, which he established in 2009. He also served as the chair of the IRP, as section editor for the OSU. Dr. Paul directed COVID-19 testing for OSU, for Oklahoma State, and served as the clinical director for the newly established Oklahoma Pandemic Center for Innovation and Excellence. He also served as a technical consultant for the Defense Threat Reduction Agency, where he worked on global pandemic preparedness projects. Recently, he also served as the PI on USDA-funded project to develop a health advisor with the US Department of State, as a consultant for US aid projects, and as a reviewer for the NIH. He also serves as a visiting professor at the New Vision University, Georgia, and as a clinical professor emeritus at OSU. I request Professor Anil Paul to please come and chair the session, the panel, and also request him to introduce the other panelists. Thank you.
Thank you, Dr. Sandhu. I would like to thank you all of you for staying back and participating in the day-long recorded festivities. And I think like we're very optimistic. This is just a nice way to just to know each other. And I think moving forward, there'll be many more occasions to work together. I think this topic of antimicrobial resistance is very close to my heart. I work in this field for a number of years. Primarily because antibiotic resistance is a significant global health issue. And it is closely intertwined with the One Health. And that's why I think it's very relevant for this particular symposium. The One Health approach is a multi-dimensional approach where we acknowledge the human, animal, and the environment as they are interconnected. And as we all know, in the previous panel also it was discussed that the cause of antimicrobial resistance is primarily the overuse or misuse of antimicrobials. One of the issues which I have faced in India is antibiotics in India are available over the counter. Whether we like it or not, it is available. When we talk to government of India, they say, well, we have policies in place, but policy is only good when it is implemented and enforced. I can sit here on my chair and order online any antibiotic I want. And as a formality, I'll get a call from the supplier saying, you have ordered this thing, what's the age of the patient? I will say whatever I want to say, and they say it is approved. So formality is complete, but it's a problem. So antimicrobial use is not only in animals, we talk about animals as a growth factor, but I think we have policy issues also. I'm glad Sasani is here. I think we have to enforce, because let's be honest, I think Dr. Nandkishore mentioned about this plants carrying extra stuff, but we also have to remember what we carry with ourselves. I sit on a plane at New Delhi airport on a United 83 and fly to New York. 14 hours later, 16 hours later, I'm there. So whatever I'm carrying, I'm giving and distributing in New York. So I think we have to understand that these issues, these infectious diseases or antibiotic resistance, they don't respect national boundaries or even state boundaries. When we talk to government of India, they say health is a state subject. What does it mean? That if something is going on in Tamil Nadu, it will not affect Andhra or Tamil Nadu. We have to look at the holistic picture. So I think that's why I have this passion for global health, and I have been doing this for the last 7 years. The other issue is infection control. I think we have some poor infection control issues, primarily in hospitals, and I think we have one of panel members will be talking about. And as I mentioned, global travel, global trade. We know how West Nile came to US. It was because of trade. Initially we thought malaria will not come to US. It is there. But are we prepared for it? So I think there's a lot of issues, but I think global travel and trade are also important to understand the antimicrobial. And I think it's my privilege to introduce our panel members. We have Dr. Akhilesh Krishnan from Oklahoma State University. I know Akhilesh for several years, and we have worked together literally day and night during the COVID. He and myself were working in the COVID lab. And a lot of times we at 2 a.m. he would go to Taco Bell to grab something. So Akhilesh and myself, we go very well. On a serious note, Akhilesh is a faculty member at Oklahoma State University. He specializes in environmental sciences, particularly in soil and water resource management. His research focuses on sustainable agriculture practices, soil health, water quality, and impact of land use changes on ecosystem services. His work is aimed at developing sustainable solutions to address environmental challenges related to agriculture and natural resource management. His research often involves fieldwork and lab studies to examine the interaction between soil, water, and that's what we call One Health. And is actively engaged Okay, but right now Akhilesh has a grant on One Health, which is working on, and I think they are looking at, if I remember correctly, on animal wastewater surveillance, right? Okay. Okay, my memory serves me right. Okay, so that is one of the areas he's working on, and I think it's a real pleasure to welcome a close friend from Oklahoma. The next one is Professor Shelja. Heard her since morning, and she's been doing a wonderful job, and I think very proud and privileged to work with her for last few months. She has been with PHFI from 2009, and she's trained as a physician with double masters and PhD from India and masters in medical science from Sweden. From Karolinska, hygiene and tropical medicine. Was through Wellcome Trust Fellowship. Her interests are to explore public health impact of transportation choices, especially on injuries, physical activity, and air pollution. She also works on environmental and health disaster management. She's an associate editor of Cochrane Collaboration and is an invited member of the Cochrane core editorial board as an injury expert. She is currently the Dean of Research and Policy Support at IAPH. Thank you, Dr. Shelja. We also have Dr. Sipsen. I need to give a special welcome to Sipsen because he was not doing well. He was literally in the hospital this morning. But he preferred to be here with us. And thank you for being here. Sipsen is also a physician and currently working as associate professor at IIT Hyderabad. He is passionate about teaching and research. Previously served as ICM at National Institute of Epidemiology in Chennai, and also at Apollo Institute of Medical Sciences in Chittoor, and CMC Vellore, and Government of West Bengal. His research interests include primary healthcare, infectious disease surveillance. Surveillance is his bread and butter. He loves surveillance. And the core of epidemiology. He has over 50 publications in national and international journals. He is an editorial board of the PLOS Global Public Health Journal. 80%. Welcome, Sachin. Last but not the least, we have Dr. Krishna Veni. She is the antimicrobial head of Star Hospitals in Hyderabad. I think she is online. Dr. Krishna Veni is the unit head at Star Hospitals in Hyderabad with extensive experience in healthcare management. She oversees hospital operations, focusing on providing high-quality patient care and implementing efficient administrative strategies. Her role involves coordinating various departments, optimizing hospital resources, and leading initiatives that enhance service standards. I think that's it. Do we have everyone online? Okay. Oh, hi. Okay. I think let's get going, and I think I'll ask to talk about the antimicrobial resistance issues in a hospital setting, because I think we may not say we have overuse, but I think we have some issues because I think with the Dr. Google available many times in our practice, we get the patients who have already decided what antibiotics they want, When I went to medical school, my professor in Chennai told me that if you have common cold, you treat it, it takes 7 days. If you don't treat it, it takes 1 week. So, which I still believe that's using treatment. I think that's about the use of antimicrobials and what needs to be done in a hospital setting, mitigating the antimicrobial resistance. Over to Dr. Shuri.
Good evening, all of you. Am I audible, sir?
Yes.
To the audience?
Yes.
Okay. Thank you for a very nice introduction which was given in this program. Good evening, all of you. So I'm Krishnaveni. I'm unit head of staff hospitals. So I'm going to talk about how do we actually manage this whole antibiotic usage and the rational usage of antibiotics. So quickly, it is in 2 steps. The first part, so first is all the hospitals do understand AMR is a global crisis concern. So all the hospitals are now aware and oriented into understanding and contributing their level for how do we control this whole concept of AMR. So that is well understood by the hospitals. Even the NABH emphasizes and focuses, even hospitals participating in accreditation programs do not ignore them. Coming to the whole plan or the way it is done in 2 ways. One is the prophylactic antibiotics. So the organizations, we define what is the prophylactic antibiotic policy. So after we define this, generally these are the EC or ICS surgeons. After we define, a very important step is to bring the awareness that we have this policy in place. So that sometimes there is some new doctors coming, there are some existing doctors coming. So it becomes very important to the stakeholders. So we go ahead and give a copy to each of the surgeon and try to take the signature so we do not miss this communication. So complete information to the surgeons that we have the prophylactic antibiotic policy, and then a display of a copy in all the relevant areas to the nurses, to the technicians. So everybody in the process are kept informed about. Now that being done, a very important step is to monitor. So we do something called audit. So we do a retrospective audit every month of the previous month to see the compliance of all the surgeries which are done and what is the prophylactic antibiotic dose which is given. So there are some protocols about 60 minutes of antibiotic dosage before the incision, which is more effective and safe for the surgery. So we audit both the time of the administration of this prophylactic antibiotic and see the compliance whether this antibiotic is as per the policy. After we do this, now we have the data of deviations and the compliance percentage. We are almost at 94% compliant. We started with 60% of compliance and now we've moved to 94% compliance, which is a very big thing, which shows that consultants and physicians are also very much aligned to this step. Now, here we have deviations data. It becomes again very important that these deviations are not left alone or just spoken as percentage, but we need action. So the best way we have found, which worked very well, is that you take this data and meet the doctors on one-to-one basis. So we form a small core group with the microbiologist, with the medical administrator, the infection control officer, and myself or any of my colleagues. So we form a core group and then we meet the doctor one-to-one and discuss with them that the deviations, the reasons for deviation, Sometimes it's awareness, sometimes it is the documentation gap. For example, a patient would already be on a restricted antibiotic, but when he comes to the surgery during his antibiotic course, naturally he is given that antibiotic. So these kind of reasons we can discuss, and sometimes the microbiologist will have a very good chance to explain why we need to stick to the prophylactic antibiotic. So this actually brings in a lot of coordination, and it helps in a lot of compliance to the defined policy. So this will control the misuse of antibiotics for the prophylactic course. The next is restricted antibiotics or high-end antibiotics. So each organization has its own name. Predominantly, we all have similar kind of lists, which comes with this restricted antibiotic list. Now, once we have the list, we need to again have consent of all the stakeholders, and this needs to be circulated everywhere, and we need to improve the training that this is the restricted antibiotic list of the organization. Now, what do we do with the list? So, all the prescriptions which have a restricted antibiotic needs justification. So how do we do this tracking? So we have justification forms in all the nursing stations in all the areas, and when the pharmacy dispenses a restricted antibiotic, they flag in the WhatsApp group which we've created for the monitoring. So the group is for monitoring the rational use of restricted antibiotics. So once the pharmacy issues, they flag it into this group, and the committee members, the core committee members of the group understand the justification. Now the justification forms have also evolved, and now we have very, very simple forms to capture, which is very easy for the consultants or the physicians to tick and mention the reason. Is it empirical? Is it justified because of the culture report? And if it is empirical, we have a chance to monitor whether they escalate or de-escalate kind of a thing. And this patient will be monitored to see what are the changes which are happening and whether an appropriate de-escalation is being done or not, appropriate duration is being used or not, the outcomes, the monitoring of side effects. All this is done in a very coordinated manner. Now, this small step of cohorted monitoring helps in a very large extent to control the use of restricted antibiotics. Antibiotics usage, monitoring and justification and compliance to this policy. This overall brings a lot of safety and controlling usage of the antibiotics in the organization. Now, after all this kind of a control programs, do we still have AMR programs? Yes, we have AMR organisms, and it comes with a lot of cost. So the hospital perspective is that these things, when they occur, it comes in a lot of cost for the patient and for the hospital. So now what do we do when we see a patient with AMR positive organism? We have to isolate the patient. So we isolate, so the patient necessarily will be paying the rent of a single room or an isolation room, and we have to have manpower for the isolation or barrier nursing. So that extra cost of the barrier nurse or a barrier housekeeper, so that we are at least controlling and not allowing the spread of these organisms. So once we have an organism, the focus is on how to control and prevent spread from there on. So this is what happens when we have an AMR. So then comes the root cause. We need to understand whether it is community acquired or is it hospital acquired. And when we do the root cause of understand if the root cause is hospital acquired, and the work is more to understand the source and how did this happen, understand and fix the source in a very permanent way, and look into the whole infection control program again, usage of disinfectants, personal hygiene, hand hygiene. So all these steps and causes are analyzed to fix the reason and control thereof. So it takes a lot of man hours, energy and cost in controlling the spread of AMR. So this is the overall thing which happens in the hospitals. Now, do we have challenges? Yes, we have challenges. So the challenges are the physicians to de-escalate. The challenge will be to even flex their already pre-planned therapy models. It becomes very challenging. These are all very difficult, but they're not impossible. It is also very challenging to monitor the de-escalation of high-end antibiotics in the outpatient and inpatient setups. Sometimes it does not look feasible at all to do the so this is how the whole process runs in. And coming to the next part, which I would like to speak, is the importance of collaboration in these scenarios. Now, most of the time, it becomes very difficult for us to understand the susceptibility patterns from the antibiograms which are made in the organization by the microbiologist and their team. Now, when we have a collaboration, if we can all understand the susceptibility patterns across the hospitals, in the same city, the adjacent cities and in the states to learn much better. We can also understand different organisms, how they are evolved, understand is it endogenous, is it community acquired kind of a flora. So this data of different hospitals and advanced labs which does the cultures, this will help. The collaboration with these will really help to understand this data much better. So we can also learn the treatment options, what are the outcomes, are there any side effects which these patients get by when we use this high-end antibiotics. So here another thing which I would say, which we learned over a period of time, is when it comes to an AMR or an MDR or a hand-resistant drug, so we have really saved colistin to a very large extent. In colistin, we generally use the polymyxin B. So our polymyxin A is used. Polymyxin A usage till now is zero. So we feel very proud to say that we haven't used any polymyxin A to our infected patients, and we were able to successfully treat them with polymyxin B as of now. So this kind of insights, when the organizations collaborate, they can learn from each other, they can share their data and analyze, and the data will be very insightful to conclude and improve upon from this kind of learnings. Another very important challenge is hand hygiene. Now there is a lot of convincing data that effective hand hygiene can definitely reduce the hospital-acquired infections. It has been proved at various levels and multiple data, and when you see the root cause, the breach is hand hygiene. So in this collaboration, the organizations can learn how to implement this hand hygiene programs very effectively. So how do we learn and how do we improve? When we have the data of what is our actual compliance, so how do we audit hand hygiene? Even the tools which we have in hand hygiene, from what I've seen over 10 years, there are very good tools which have evolved very good techniques to capture the data. But some organizations still have some better techniques. So the sharing of this knowledge on how to audit hand hygiene and get the correct data so it can actually improve correctly will also help to implement a very good hand hygiene program. And again, that will actually help to prevent hospital-acquired infections. So if you see this, like if you're listening, it's a very big vicious cycle between the infection control, the hand hygiene, and infection control of hospital-acquired infections, the prevention of hospital-acquired infections, and then the usage of antibiotics. So somewhere we need to break this cycle, we need to break the chain, and for that we have to collaborate. And One Health is an amazing concept. I have actually heard about this a lot in the G-Spark conference. Very comprehensive, very intense, and I'm sure when we collaborate and we all learn and implement these kind of insights, we will definitely have a good antimicrobial stewardship programs coming up in the organizations.
Thank you.
Thank you so much for giving me this opportunity to talk in this program.
Thank you, Dr. Kishore. That was I would request Dr. Akhilesh to give his perspective because he is in a unique position of working in an animal diagnostic lab, but also dealing with human infections. I think we have seen, at least during my visits to his lab, the animal infections passing over to humans and human infections passing over to animals. What has been your experience about those, I would say, interspecies transmission of infections?
Thank you, Marco, and thank you everyone for this opportunity. So, more than the interspecies transfer, I think can you hear me? This is very one confusion we have on the veterinary side is how effective many antibiotics are. On the human side, it is quite easy. You have a patient come in, and you know he's a human being, and you know what treatment to do. My wife, she's a veterinary practitioner, and especially in the US, she doesn't know what patient is going to come to her. She's come home and said, this is probably the first time I've seen this species. I don't even know what the species is. And you have to treat those animals. Now, treating those animals, the issues are you don't know what the pathogens are, you don't know what the dose is for those animals, and you don't know what the effective antibiotics are. So once you take that into account, the veterinary field becomes so complicated in the sense we do not have MIC values for many antibiotics. And I'm wondering all the students here know what MIC values are. Have you had a microbiology course? Yeah. So MIC is a minimum inhibitory concentration of an antibiotic. And that is determined in many cases based on what an effective concentration of the antibiotic is that can kill a bacteria. Let's take any infection. In humans, it's been established. In animals, probably it's established only in one species. It might only be established in So you're going to treat a species of animal that you don't know in some cases, and you might know in some cases with an antibiotic that you don't know what the MIC value is. And now that can contribute to and that's a huge problem on the veterinary side that we have. You don't know if the doses we're using is good, and it's a problem. It's not unique to the US. It's an issue that all of us veterinary clinical diagnosticians, microbiologists are dealing with. And coming to your question on the species, the cattle, the common animals, we know the zoonotic pathogens. And we've seen infections. It's quite common to get anthrax, or the skin called anthrax. In Oklahoma, we have a condition called tularemia somnolens. Tularemia is so common in people dealing with rabbits or squirrels, that kind of stuff. But when it comes to these exotic species like a sugar glider, that many people have snakes, what bacteria there? Salmonella is common, we know, in many of these species, but what else is there? And that's where the technology aspect comes into. You start doing metagenomic studies, and you identify now you have a patient that you don't know what the species is. You do metagenomic studies and you get a bunch of bacteria that you've never heard of. And then the clinician needs to know are these bacteria pathogenic or not. And they call the microbiologist and ask what do you think. And we give them an idea of what to think. At least we try to group the bacteria into a family level. If they belong to let's say if it's a respiratory pathogen and you find something in the Pasteuracea family, you assume that it might be relevant. So there are unknowns in that case. You don't know how risky it is to them to transfer to humans and any other species that it can. So in this case, what people mostly do in the microbiome study is look for bacterial microbiome. It is very rare that people look into other pathogens in many of these species. We started doing a little bit of studies in some of these species. The virome is way more exciting than the bacteria. And how much of that virus is consumed into humans, it's again something that we don't know, but we have to look at.
I think the question I have for you is, where do you think the research between different specialties, different groups should focus on to mitigate the modern challenge which we have in microbial resistance? So I think what should be done? I know at a policy level that there has to be a reach for policy, but at a research level, what needs to be done?
Thank you, Dr. Paul. We all know that antibiotic AMR, basically, the resistance, we have very little information on that. Although there are estimates, in terms of accuracy, we don't know how accurate they are. Because we know that this is just the tip of the iceberg thing that we are talking about. And it's across. I mean, when you look at humans as well as now, if you look at the One Health perspective, in animals, in plants, etc., in livestock, it is anybody's guess, although there are estimates, as I mentioned. So, the thing that we are familiar with at the household level is that some person has felt, has fallen sick, has taken antibiotic for 2 or 3 days, feels better, and then discontinues it. It's very common for us to hear such things. It happens in our own households. That is one thing. The second thing is that when somebody in the household or their friends fall sick, then they call each other and say, hey, I had a similar thing. I had fever too, 3 months back. I have some antibiotics left. Here you go. Use them. And then the other person is happy because they're cost saving, because some of the antibiotics can be expensive. Again, that other person could take it for 2 or 3 days and then stop. So to answer your question, Dr. Paul, I think we need accurate estimates of, first of all, what is the antibiotic consumption, again in various sectors that we're talking, not just humans. That's one thing. Second, we do not also know how much of it is at the resistance, how much of it is at the community level, and how much is at the hospital level. Again, we have estimates, but in terms of accuracy, we're not sure. That's another area of research. And the third thing is in terms of the resistance or the sensitivity patterns. We have some idea, but again, we do not know how accurate they are. At least for these 3 important things, it will be very good to proceed with more accurate estimates, is what I'm thinking. And the fourth thing in terms of research, again, we should do interdisciplinary, transdisciplinary research and talk to sectors. Otherwise, we'll just be working in our own thing and we do not know what is happening in the next institute. So I think it would be good to start off with these 3 and then see what are the intersections in terms of animal, plant, livestock, human, etc. And to see the whole thing. It's just the Olympic rings that we have to juggle and not just look at our own thing in terms of research also. The same concept for One Health should, the same thinking should go into research for all these sectors. That's what I'm
I have a question for surveillance. What
I'll give you a short example and my life experience. Usually I like those to answer to your questions, of course. Um, I was somewhere in southern part of the country again, and I was involved in a fever surveillance. The main idea was salmonella species identification to make it for the room easier. We were looking for typhoid cases. It was a community level typhoid surveillance to be specific, and we were looking for kids who are having fever for more than 3 days, and then we also captured, or we were also capturing that whether they are taking antibiotics and how is the antibiotic use pattern. Slowly we realized that there is something, a complex relationship exists in antibiotic usage. So when we went to the house to house, for house to house surveys, and then we realized that a child, school going child, let's say, having not even one whole day fever is also taking antibiotic. Why? They have to go to schools. They cannot miss schools. And therefore, the parents are anxious. They are taking to the doctors. On the other side, doctors, when they are trying to say that no, for one or half day or a single episode of fever, you should not take an antibiotic. You should be on something called a conservative management, like paracetamol, like hydration. Most of it are by fever. Then parents stamp the doctor as not a good doctor because they require antibiotic. Send the child. Not only that, the child goes to the next doctor. They are not happy. The parents are not happy. They go to the next doctor. The next doctor says that okay, do some blood test. They're asking for what? Vital test. Apart from let's say the usual routine tests. Vital test in India obviously will say that okay, some 1:80 or 1:160, which is very much common, which is you cannot accept 0. They mark it and they say that see the other doctor did not treat you well. So we are starting on antibiotic. So antibiotics started. In this complex relationship, what else happens is like the influence of the medical representatives. I will take to the, it is a fact. You take to the industries, their ideas and their promotion, how you can use antibiotic more. And therefore, they are pressurized, doctors are often pressurized that use antibiotic because of liver XYZ reasons. I'm not going into that. All right. So in this complex relationship, what we try, coming back to your question, sir, is antibiotics. One we did is like yes, understand through this fever surveillance or through even for diarrheal surveillance. Also, we see in diarrhea we give antibiotic taking which is treated with simple ORS. Now, that is one way of solution. We establish, apart from hospital level surveillance, which I am sure that we heard Dr. Krishna Beni, and we know that yes, we can do that at the hospital level. But as Dr. Shailaja said, at the community level, if we come, then these are costly surveillance, of course, but still, yes, we can do that, at least for the targeted populations like pediatric population where antibiotic usage is very high. And the second one is even we can get this information from the from pharmacy stores. As you said, over-the-counter drug usage are very common. So that is the second option. Third option is even we include the pharmaceutical companies that hey, what is your usage pattern for one single district or a single state, and then we get a holistic idea at a state level or a district level or any administrative level, what level of antibiotic usage has been done so far. And the other part, antimicrobial resistance or sensitivity pattern, to understand that, I think that is very costly and that is high-end test. So we should include the, let's say the tertiary care hospitals collectively, not single hospital, to understand that what is happening. And similarly, because I am not very sure, I'm not a veterinary person, we can, of course, we can include that side as well to understand what level of antibiotic has been used.
On the research side, looking at newer approaches for antibiotic resistance, we have done some studies, we have done some using nanoparticles, nanodiamonds for relatively low doses, and it's been pretty effective. So the latest one is the FARG. So what is your thought process on that one? Because I think it's pretty new concept in India, but I know you have been working in that area. I think that's something which we are also interested in. So,
I wouldn't say Fudge is pretty new. It's in the 1950s or 60s, whenever it was. It's new in the sense it's got a revival at this point. People are looking into it with all the AMR issues going on. I think, if I'm not mistaken, in the Eastern European areas and in Russia, they used to do fudge treatment long ago, and they used to have well-developed systems where you could make fudges on a bespoken, custom-made fudges. So instead of using generic fudges, if you have an infection, the lab cultures the bacteria, gives it to the fudge lab, and they make fudges for that. So it's personalized medicine in a way. Like that. That's quite, to me, it's quite interesting. It's something we need to look into. At least fudges are natural. It's not something unnatural that we are adding into the human system. Someone mentioned about cricket, and in my mind, bacteria and phages are in a constant game of cricket going on. Phages are throwing bouncers at the bacteria, and the bacteria are trying to figure out. It's like the body line period where the batsmen at that time were trying to clear it out. And once they figure it out, there is resistance in phages also. So once a bacteria figures out a method on how they can get rid of the phage, a new phage comes in. So to me, phages are, it might not be a treatment that we can do on its own, but it can help in reducing the dosages of antibiotics, especially if we use it in combination. That's something we're trying in our lab right now. And especially for multi-drug resistant bacteria, we have developed phages against MRSA, phages against Salmonella, multi-drug resistant Salmonella, E. coli, Enterococcus. All these pseudomonas, the innately multi-drug resistant bacteria, as well as bacteria that have acquired multi-drug resistance. And they are quite effective. The challenge with phages is going to be, phages are also highly specific. So if the bacterial strain changes, it might not be effective. And that's what we are evaluating at this point. We've got around 100 Pseudomonas isolates that we've got from otitis external cases and drugs. And we're trying to see how much of those phages, we've screened for phages against all of them, and now we're trying to do a checkerboard and see, does phage 1 that was isolated for bacteria 1 affect bacteria 2, 3, all the way to the 100 that we have? And if so, that would be, I don't expect it to be, if so, we would like to sequence it and find out what specialties it's got, and see if we can synthesize the phages in the lab, and do some recombinant synthesis and make more of those kinds of phages if we can. The other aspect, is antimicrobial peptides. Is also a concept that's relatively new, but that's also been around for so many years. It's again natural. And we're looking into antimicrobial peptides as well. And definitely what we found with at least a couple of peptides that we've tested is it significantly reduces the dosage requirement of antibiotics. And we don't know how it's happening, but the thought process is probably it's making holes in the bacterial cell and making it more permeable to the antibiotic. And in addition to doing the peptides, we are also seeing if we can make synthetic molecules that mimic the, uh, the physical and chemical properties of a peptide. So if we know that a peptide molecule is effective, we are trying to find out where it acts, and in many cases it's these outer membrane proteins or whatever pumps the bacteria have. Right? And the 3D structures of those are all the protein. And what we're trying to do is using AI and machine learning. Dr. Agarwal is helping with that. They are trying to design, based on known peptides that act on them, design molecules that can mimic that we can produce in large quantities and look at effectiveness of those. So those would also help to bridge the gap in new antibiotics coming out. It's not going to be an easy process, but it's something new that we are trying as well. But yeah, in short, to answer your question, I think phases are promising. I hope we can administer them other than topical, intravenous. We'll have to develop what other methodologies are needed to administer the drug, right? Administer the phases to go into whichever system it has to act on. But it's definitely effective against multi-drug resistant bacteria that we've tested.
Thank you, Dr. Krish. One thing which we have been working on is developing receptor analogs, particularly for UTI E. coli. That has been pretty effective. I think bacterial colonization leads to infections. So if we are preventing bacteria from colonizing itself, I think there is no need for antibiotics. So that attempt is being made, and we have done some receptor analogs. So there are different methods of doing things. The question for Dr. Shah is, when I was in medical school, or even practicing in Chennai, our standard used to be cultural sensitivity. That was the first step. I think that is going away. Is that right?
Thank you, Dr. Paul. I'm not an expert in that, but I think that there are newer ways and they're more rapid diagnostic tests for culturing, mainly to see if there is resistance and what the resistant panels are. And from what I know, the time required for getting the test results back, right now it takes around 72 hours. But what I hear is that that time is going to shrink more and more. And that will be very useful because otherwise people start an antibiotic without knowing the report.
I was really looking to the training we used to get is that don't prescribe antibiotic before you get the culture results. I think that is going away. But on the technology side, I think it's very valid. I think there is now companies like William, they have come with these panels. They can screen for, let's say, 140 different bacteria and viruses and the antibiotic, and the results can be obtained within hours or days. So I think the technology is moving very fast. The cost is also coming down. It used to be very expensive, and even unfortunately working with the and the cost has come down significantly. They have now different panels, GI panels, EDI panels, respiratory panels. So I think technology is secure. I think very few places now they rely on cultures. Cultures are almost history. And I think COVID, one good thing which came out of it, now everybody knows about RT-PCR. Which before COVID, not many people knew. But the technology is much better.
There's a large difference in certain areas like in urban settings and in the capital cities and things like that, the technology aspect, it's taken up very well. But if you move to the peri-urban areas and then to the rural areas, they still have that 72-hour culture report that people wait. So that we see that it'd be good to have that gap reduced, and moving forward, I think that is one of the things that will happen because it has to catch up sooner or later. And I think the newer technologies will help in seeing that it happens. Right now, I still see that there is some differential, much more in some areas.
less in the urban centers. But you're right, it has a huge potential.
Primarily from my experience in the US, antibiotics in the poultry. I live in Tulsa, it was very close to Arkansas, where Tyson chicken people are. They used to give antibiotics in 64-gallon drops. So I think that's a huge issue. It's not only here, it's global. The other issue is there is no monitoring. One shocking thing which I found was that bananas come from different South American countries, at least the US market. They were spraying them with antibiotics. I used to ask them why. They say it increases shelf life, but even if it increases by 1 day, it's billions of dollars revenue. So everybody has different motivation. So I think there are different battles we have to fight, but these are real issues. We go to grocery stores, at least I'm not in the US. Produce, they have the sprays. Now they start adding antibiotics into those sprays. So I think it is widespread. And, unfortunately, some of the large chains in India are copying things. So that is one of those are challenges. I think for you, I think I will stay with the surveillance. What should we do?
Big question. It apparently looks like the shortest question, but this is the biggest one. One word, short answer, integrate. I think we are coming almost to an end of this symposium. And here is the opportunity. I feel that we have representatives from everywhere in this One Health role, what we are calling, especially the representatives from all the institutions here. I'll just take an example of to answer that question. One example, poultry antibiotic use. Finally, it is going where? Through the excreta, going to the environment, mixing with soil, mixing with water, and I think all the institutes lies here works on those aspects: human health, poultry health, water, soil, everything is there. Veterinary, everything is there. We have to understand how we can integrate. We have rural health stakeholder as well. I mean, how we can integrate effectively with smallest thing possible. For example, if we say that, okay, let's say the morning the discussion started, I was not here and I heard afterwards that healthy village concept. Healthy village concept, take a village, can we jointly draft our concepts, put together, share with each other, come to a consensus that this is what we can do with these objectives, simplest possible objective. I'm not saying too high-fi. Let's say A bar and all, yes, there are many teams who are working on this. It's not going to the practical aspects, what we can identify, the problems, challenges. Let's see how practically we can solve it together. So that's my answer to your question.
Thank you, Dr. Susu. I think with that, like conclude with this, that there should be integrated approaches and strategies. I think one of them is surveillance and monitoring. It will be very important. Particularly use antibiotic use and resistance patterns in humans as well as animals. I think that will be something. Second will be education and awareness for everybody. Includes whether it's healthcare professionals, whether it's veterinarians, farmers, and general public also. I think that awareness has to be created. And education, I think it's as a public health professionals, I think it's our responsibility to do that. The third one is of the policy side. Policies have to be there, but policies have to be enforced. And I think without that, we can have. I think there has to be support on that side also. Then the lastly, and also very important, we have to also invest in research and look for newer approaches to deal with infection and infection. Those things will be very, I think I would say that these are the 4 pillars. So I will ask audience if they have any questions for the panel.
Sir, a very nice discussion actually. So I'm Dr. Sujata Singh from PVNR University. So I'm a technician, so associate professor. Sir, just I want to ask Akhilesh sir. So what is the research is going on in EMR sir, in Oklahoma State University? What the research you are doing presently is the EMR? Is there any particular research is going on?
So I work in a diagnostic lab, the Oklahoma Animal Disease Diagnostic Lab, and we test samples, the clinical samples that come and isolate the bacteria, perform MICs, and look for resistant bacteria. So as part of that network, we also work with the National Animal Health Laboratory Network, which is part of the USDA, and we also work with the FDA veterinary component. So with both of these entities, we have projects going on where we do whole genome sequencing and try to identify clones and genes about AMR, basically genes that cause AMR. So that is one aspect that is going on. We are trying to identify if there are any specific traits or anything going on within the country as a whole. It's not just Oklahoma, the whole state, 50, not 50 states, all states that have a diagnostic lab participate in that, and that's a huge endeavor that's going on right now at the national level that we are contributing. Then at OSU, we have grants, research grants, research projects on which we are working on, and those mainly involve development of the phage that I mentioned. So we are screening for phages, trying to look at alternatives for antibiotics. Are there any alternatives that we can use for antibiotics? We've looked at some herbal products as well, some plant-derived things, but the main focus is on trying to develop phages and also developing peptides, designing peptides. Basically, we're trying to use not use peptides that are already in nature. What we're trying to do is see if we can design peptides against known targets in bacteria. So identify what would be the weak points in bacteria and try to develop peptides against them and look at efficiency of those, ultimately with the hope that we can use them as a drug. That's a hope that we have. But yeah, those are the main projects going on.
One thing that macrophages are very specific in their action. So it will be very detrimental if you are producing and acting against the different bacteria. What I feel, it is not that much safe to use in a common study.
That's the same thought that we've also had. Bacteriophages are definitely very specific, but we've also isolated some phages that have broad activity. And if we even use the phages, the goal is not to use a single phage. We would be using a cocktail of phages and try to use that. So, and in addition to using the phages, we would also try and isolate the actual pathogen and develop. Screening for phages is not a very complicated procedure. It's stuff that's been done for several decades that people have developed and optimized the procedure. So isolating a phage would not be a complicated thing. And in that sense, it would be advantageous because you're doing a patient-specific treatment at that point.
Thank you so much, Dr. Akri. With that, we'll end this session. And if there are any questions during the break, we can probably take questions.
Thank you.
Thank you, Chair, and the panelists, including me, for that wonderful session, for that very nice panel. And thank you so much to Krishnaveni Garu, who was patiently waiting for us online all this time because the sessions got pushed. And I thank you a lot, Krishnaveni, there online. Thank you for joining us. We will meet up sometime in person. Thank you. Okay, that brings us to the last panel for today. It is on community engagement in One Health initiatives. And I would like to invite our next chair, Professor Acharyalu, Dean, School of Management, University of Hyderabad. And I request Nirupama, please, Dr. Nirupama, to present, sir, with a plant. I'll do the introduction in the meantime. Dr. Acharyalu is the Professor of Operations and Supply Chain Management and coordinator for the MBA program on Healthcare and Hospital Management at the School of Management Studies, University of Hyderabad. With over 18 years of teaching experience and 10 years in the industry, he is a recognized expert in operations, supply chain, and healthcare management. His academic qualifications include a bachelor's in chemical engineering from Andhra University, a master's from NIT Warangal, an MBA in marketing and finance, and a PhD in management from Osmania University. Dr. Acharyalu has an extensive publication record with 40 research papers in national and international journals and around authored books on topics ranging from logistics and supply chain management to healthcare and hospital management. His global contributions include presenting at international conferences across the US, Australia, Singapore, and other countries, and serving as a visiting faculty at the Asian Institute of Technology, Bangkok. He has supervised 7 PhD scholars and is currently guiding 4 more in the fields of operations and supply chain. As a Vice President of the Indian Subcontinent Decision Science Institute, he plays an active role in advancing decision sciences in India. In 2017, he was awarded the AIMS ICFI Best Teacher Award, recognizing his contributions to management education. I invite you, sir, to please invite the panelists. Over to you. Thank you.
Thank you, Professor Salil Madam. Last session, but not least one. I'm very happy to associate with this last panel discussion. On community engagement in health, One Health initiatives, which is very important in the present day context. Of course, so many technical sessions happened so far, but this is totally different as I think. Most of in general and mostly management oriented. So anybody can participate in discussions on this topic. Today we have eminent speakers for the session. I request, I invite the session speakers into the dais. Dr. Susmita Sundar, Dr. K. Shivasanti, Dr. Suchindra Pujari. It's my pleasure to introduce the eminent speakers here. Dr. Susmita Sundar, Head of Life Sciences, Research and Innovation Center in Hyderabad, RSCH. A Life Sciences and Management Specialist with a deeply held passion and curiosity for entrepreneurship, for entrepreneurial mindset, passion for entrepreneurship in the life sciences sector, and also the entrepreneurial life mindset has begun while doing a PhD in biomedical engineering and also a course in management of technology from National University of Singapore. She is also very much involved in startups to programs such as Singapore, Stanford, Biodesign Technology Launch. Her professional journey began in entrepreneurial education, training in ISP's Center for Innovation and Entrepreneurship. This was an innovative program designed to foster entrepreneurial mindset in engineering students by linking their entrepreneurial and innovative behavior to their education and career pathways. She is also a learning consultant and program manager position for social impact programs such as Chief Minister Scheduled Tribal Entrepreneurship and Innovation Program, and also training participants to set up businesses, and Atal Catalyst by SB, and also one distinction that he has carrying the top 100 Digipreneurs from Atal Tinkering Labs, Atal Innovation Mission. All of this experience with these startups and entrepreneurships and innovators led to the role of Head of Life Sciences at RSH. This is the nodal agency for Hyderabad Science and Technologies Cluster. At RSH, her work involves fostering greater collaboration between various entities in research and innovation, space programs, RSH Aid, Samadhan at the rate of Rich, and other many national and international programs, which are mission aligned projects. Thank you, madam. Welcome. It's a privilege to introduce Dr. C. Harsha Reddy, Director, Institute of Management and Technology, IMT Hyderabad. He is a director at IMT and also a passionate academic leader for the last 2 decades, facilitating quality learning environment for various stakeholders of the management students and also management education in India. Dr. Reddy is alumnus of LSE, London School of Economics, and attended short-term programs at Harvard Business School, ISB, and IIM Calcutta. He has published a book on banking and insurance and several research papers in areas of banking and finance and fintech. He worked in research papers and research projects with NABARD, NPCA, and conducted several training programs and in years digital banking and treasury management for bankers in India, Nepal, and Bangladesh. But Reddy is CIA Southern Region Education Task Force member, Steering Committee member of CFO Forum, CIA Telangana, State Council member, Associate and Advisor, Hyderabad Management Association. We welcome you, sir. And the last session speaker, Dr. Suchitra Pujari from NIRD PR, Hyderabad. She is a sociologist and trained demographer with a master's degree in sociology from University of Hyderabad and a PhD in population studies from the International Institute of Population Sciences, Mumbai. Her work encompasses extensive research in women's health, child development, reproductive health through a gender lens. She has contributed both national and international projects funded by organizations like World Bank, DFID, UNFPA, and India's Ministry of Health and Family Welfare. Prior to joining NIRDP, NIRDPR, she taught sociology at undergraduate level across various colleges affiliated to the University of Mumbai, and she is currently assistant professor at NIRDPR, and she also initiated organized numerous capacity building training programs on rural health and gender for master trainers as well as state and district officials responsible for implementing health development schemes. She was also a member of 15th Common Review Mission for National Health Mission in Bihar and compiled a national training module for block health officials as a part of the aspirational block program by NITI Aayog. As a part of APP program, she was conducting training partnering with UNICEF to the block health officials for the southern states of. She also collaborated with National Health Resource Center to conduct national training of trainers TOT programs, specially designed for training Panchayat Raj institutions, members, and also focused on health issues. Her research integrates a strong gender perspective, examining the role of PRIs and also self-help groups in rural health and development. She is currently on the impact of social norms on maternal and child health outcomes among indigenous communities. I welcome you, madam. So this session is actually community engagement in One Health initiatives. So let me give a small remark on this, and later on I invite the speakers to have a brief comments on the brief ideas to share on this topic. As you know that from the morning, One Health, what is One Health initiative, everybody is knowing. So this symposium is going to look at how you are looking at the interconnected health with environment challenges, and also how we are going to look at cultivating and fostering the resilient, sustainable communities. And what is the role of community engagement? How do you bring the interconnectedness and interdependencies of health and also environmental and animal space? This is going to look at how we are going to amplify the disease prevention and also how we are going to enable timely response to healthcare risks or health risks, and promoting environmental community-based models. So there's so many models are emerging, community engagement models. So what are the current models that are happening and their challenges and issues, and what could be the futuristic models that are evolving? Looking at the changes in the environmental changes, climatic changes, and human health. And also human health is very important, that the population is going to increase 1.7 billion by 2050. So health is a major concern. How health is dependent on different factors. And also how different sectors are involved, government and private organizations. How do they take care of the environmental factors? How do they work together? How do they share knowledge, resources, and to come out with a viable solution, and also formulate a policy to the government? How do we implement the policies? There are differently. How do you bridge this One Health initiative? Also, how do you bridge the gap between the health policies and the real, what is at the ground reality implementations? So I I think all of you should look at how the community is going to play a crucial role towards healthier planet, and also look forward the ideas of these today's elite speakers. So with this small remark, now I welcome Dr. Sukuta Sundar to give her thoughts on this topic.
Thank you, sir, for the kind introduction. Firstly, thank you, Prof. Paul, for inviting me. Indeed, this was a wonderful day, though a long one. So without further ado, I would present my thoughts as a story. As a mother of an 8-year-old, I'm so used to stories, so I thought I'd do that. And since this being the last session, I hope not to put you all to sleep. So this story is A, B, C, D, E, F. So the 3 letters of my first story are B, C, D. B for bat, C for cow, and D for dog. And the letter that connects the bat, cow, and dog is animal. So A, B, C, D is covered, okay? So the first story on bat, when COVID hit, the carrier was bat. It was an unknown attack. Nobody knew what it was all about. But there was a strong intent from the top, that is from the government, and resources were ramped up for usage of vaccine research, vaccine production. Resources were ramped up for diagnostic kits. So RICH is part of Office of PSA, Principal Scientific Advisor to Government of India, under their megacity cluster projects. So there are 8 megacity clusters in Hyderabad. RICH is the Hyderabad Science and Technology Cluster. So during COVID time, RICH was part of Hyderabad's Reagents Consortium, which was part of the National Reagents Consortium for making India indigenous for rapid diagnostic tests. So there is one company called Human Life Sciences, far away in the Medical Devices Park in Sultanpur, quite close by. And this company was the one among those companies which were instrumental in making RT-PCR test kits. The world didn't know how to diagnose COVID. Human Life Sciences, they manufactured the genomic probes, reagents for the RT-PCR test kits. And it was not the individual effort. It was one startup, but they needed reagents, which was collected from MSMEs around. It needed to be validated. So the research institute, CCMB, played a huge role in that. CCMB was part of this entire consortium, and it was funded by FIND. So FIND is an institute which was part of the funding. So there was a clear intent from the top government in a reactive mode, but in a mission mode. So that's my first encounter of unknown attack. My second encounter, which is my second story, is cow. Cow, one of my friends in my neighborhood, as a peer, I got to know that they had an unknown disease, went to pillar and post through various hospitals. There was no diagnosis done, spent multiple hours trying to understand what was the cause, spent huge amounts of money. Insurance was not covered because the cause was not known. It was an outpatient treatment so far. Finally, after 4 months of gruel trouble, they found out it was brucellosis, which is not a zoonotic disease transferring from cattle. It was not an unknown attack, but it was a rarely known attack. Doctors were not aware. Doctors were not trained to identify zoonotic diseases. Diagnosis was there, but it was not prescribed. So that was my second encounter with intersection between animal and a human health. The third story is dog. And this was something which was very close to me. Me and my friend, after almost 15 years, so I used to backpack when I was studying in my master's in Germany. We used to go to different cities, just go walk along the streets, explore the place. Early this year, me and my friend got such an opportunity in India. We went to a place called Jodhpur, not a small village, not a town, it's a touristic place. And Jodhpur is known as a blue city. The buildings, there is one particular track where the buildings are blue in color. It's highly beautiful. What we noticed there, 8 o'clock in the morning, there were dogs chasing, and my friend got bitten by it. And this is not a travel, a tourism, a pleasure trip turned out to be a learning for us. The community around knew that dogs over there are prone to biting them. They are very aware of the situation. They are known to rabies. And the recommendation at the time of attack was put turmeric and chili powder. But we didn't panic. We said, no, that's not the solution. Let's go to the hospital. Went to the hospital. We noticed that it was a very rampant issue there. On an average, every day, the hospital workers see around 250 cases on rabies. In front of our eyes, we saw people teared very rampantly by dogs. And the reason being, dogs are not being fed or they don't have access to food, so now they are attacking humans for food. And it's not a village. Jodhpur is really a good place. It's a touristic place. So animals and humans coexisting poses a One Health risk. And segueing to my final story, the F story of fish is environment. I come from a place called Kanyakumari, the bottommost part of India. And fish is our common diet. Kanyakumari, even the poorest family will eat fish for 10 rupees. And it's known that now increasingly cancer cases are detected in the population in Kanyakumari. And the reason being the diet of fish. How do fish bring in carcinogenic agents? Nobody knows. So environment is posing a risk in human health. So there is a need for One Health approach, and that's where I would want to present what Office of PSA, Principal Scientific Advisor, is doing as a national One Health mission. I wouldn't say everything is set in place. It's a mission in progress, and that's where I would end with 2 P's, and that's a call for PPP. It's a partnership for not just public and private. It's a partnership for person to person. If we want a world where we all can live in safe, I think the both partnership of vertical, which is public and private, and the partnership between people to people is necessary. I would urge you, if I have tickled your brain, look through the National One Health Mission, which Office of PSA is putting forth. It's at the national level, as Prof. Paul mentioned, health is a state subject. It needs a collaboration at the state level too. We are happy to take that forefront, which is a collaborative entity. My call is, it's a wonderful platform and we wish to partake. We work with research institutes, academic institutes, industries, startups, and government. So we would like to see how we can bring in the various stakeholders together. Thank you for this opportunity.
Thank you, madam. A nice introduction of ABCD experience. So, due to pandemic experience only, the One Health initiatives are coming up. And as you see, most of the dogs are coming up to the doors because of social distance. And also lockdown. So people are living in homes. So the animals are coming up, they are free. And suddenly lockdown is off, then finally people are coming out and dogs are staying. So that's why the oneness initiatives have really created a greater awareness of health pandemic. So, madam, you have given one concept that people to people or person to person. Yeah, we look at the community, role of community engagement. So from the person to person perspective, how do we empower? That should be community empowerment. So how do we, what steps could be taken for the community empowerment for person to person interaction or person to person responsibility?
Thank you for bringing that out. I've seen two models work in the community. One is a digital tool where grievances or such recordings can be brought to the notice. So one of those is, not sure how many of you might have used it. If there is a sound pollution around you, you can raise a complaint in the portal. So there are portals for that. So there are portals for your environmental hazards to be reported. A lot of them do not have awareness to that. I think to begin with, which I think in schools and colleges we should empower. Increasingly for cyber security as well, there are portals to report. For your personal safety, for animal food safety, there are portals, consumer portals where you can raise consumer awareness. That's one. But second one, as some of you have already highlighted, social media channels. So a lot of them are engaging on the social media, and now there are tools which government is also using to see which is the trending post, which is where most of them are making noise about, and that needs to be addressed. That in terms of civil infrastructure or anything. That's the from the community and to be made heard to the government. But likewise, I feel education and awareness is the key. We need to be aware citizens, socially aware citizens of India.
So creating awareness is also key, and also digital technology tools. How do we adopt digital technology tools, connecting the rural and urban population, and using social media platforms. These are all very critical for creating awareness and also bringing some kind of consciousness in the individuals to save the society, to save the planet, and so on. Now I request Dr. Suchitra Pujari Madam to what are the practices, one of the practices that are being there in NRI.
Thank you, sir. And I thank Director IIBH and his team for having me here. Great opportunity to share NIDPR initiatives. So just to tell you, National Institute of Rural Development and Panchayati Raj is a think tank of Ministry of Rural Development, Government of India, and we do capacity building and training programs for the RD officials at the state and the district level, as well as for the line ministries, Panchayati Raj functionaries also, department also, as well as other line ministries or RD schemes and other schemes across the ministries relevant for the rural, in the rural context. So great insights shared by the panelists through the day. And building on the discussions, I just wanted to extend the conversation to understand the key role that community-based organizations can play in mainstreaming One Health initiatives. So community-based organizations, like we work very closely with the Panchayati Raj institutions, with the self-help groups in the rural context to take these initiatives ahead. NIRDPR has been two initiatives that I'm going to talk about. Is one is, as DG sir was mentioning in the morning today, about the localizing the sustainable development goals. So there are 17 SDGs, and Ministry of Panchayati Raj has initiated this entire thing about localizing the SDG goals at the grassroots level. So aggregating the 17 goals into 9 themes. And one of the theme is Healthy Village. Theme 2 is on Healthy Village, which has about 26 indicators listed, and they have been taken from with the help of the Ministry of Health and Family Welfare data. So 26 indicators, and we are now training the Panchayati Raj functionaries the master trainers who would go down and again train the Panchayati Raj people down below on the different, on these indicators, on the listed health indicators, and how to improve these indicators at in the community, in the communities. So that is one initiative that has been taken. So that is a very good platform where we can actually integrate One Health initiatives also. The second thing is, other than the LSTG goals, we also have the GPDP, Gram Panchayat Development Plan, which is the Ministry of Panchayati Raj is this is a framework basically, which is where every Gram Panchayat has to develop a plan for its Panchayat, identifying the challenges, the priorities, the targets they have to set within a year, what they can achieve. So as Sir was mentioning in the morning today, there are a number of health indicators. But like if we say reduce the IMR, they do not know what exactly to do to bring it down. So that is where we need the intervention to tell them how to go step by step to kind of in the long run bring it down to the reduce the IMR in the community. So likewise, there are other health indicators as well. So it's a mix of indicators, both communicable indicators for communicable diseases as non-communicable diseases. We have started this training very recently. In the last 3 years, these trainings have been going on at the state level, at the district level as well. And we have also collaborated with National Health System Resource Center for creating national level trainers who would go down and train the Panchayati Raj functionaries on health, especially because you all may be knowing the 15th Finance Commission grants, they had a certain, I think 70 crore or something, which was granted to the Panchayati Raj functionaries for the first time to upgrade the health centers, to upgrade the sub-centers into health and wellness centers. But then it was realized Panchayati Raj people do not have any idea about the so-called health domain. Even if you ask them in the communities, they just say you call the ASHA, they will tell you. You talk to the ANM, they'll tell you. So they were least, involved in this. And I think it is very important to involve the Panchayati Raj functionaries because they are the grassroots leaders there. And they would spearhead the entire thing in the community. It somehow falls into place. And because they are part of the village health, sanitation and nutrition committees, the sarpans are the chairpersons of those committees, where these One Health initiatives can be, the interventions can happen there. They are part of the RK Rogi Kalyan Committee, they are part of the Janar Committee, so at the district level, at the block level, so they are involved there. But the thing is, these committees are not very active and not very functional. And these are the places, I think, where we can mainstream this One Health initiatives can be integrated. The other platform where we can do it is through the SHGs, self-help groups, women who are working. They have a huge network in the rural India. There are about more than 85 lakhs SHGs in the country today. And they are doing brilliant work when it comes to, of course, they were formulated way back in 1970s for livelihood promotion and things like that. But now the government is also looking forward to involving the SHGs in disseminating the health messages in the communities. And because they are very closely tied to the community, the trust factor is there. They know every household in the community. And they have also done excellent work. Jivika, for instance, if you may know, Jivika is an SHG group in Bihar, under Bihar Livelihood Promotion Society. And they've done excellent job in during COVID time, as well as disseminating other health messages with regard to maternal and child health also. So there are research evidences which shows that not many research has been done, but there have been research done by BMGF and others also. So SHG can be a very good platform which the community can be engaged where we can spread these messages, One Health messages. So the question is, how best do we integrate?
Thank you for the nice meetings. But NIRB, we are having a lot of community practices. So in these practices, you have mentioned about One Health Village. Healthy village. So creating a healthy village. So in creating a healthy village, who are the major stakeholders to bring in successful community engagement? Or you can say that how do you define a successful community engagement?
So as I said, the healthy village concept is being led essentially by the Panchayati Raj leaders at the grassroots level. Of course, the district panchayats are also involved, block panchayats are also involved, but the sarpanch and his entire team, they are leading it forward. And we, as I forgot to mention this, we reach the community through SIRBs. We have State Institute of Rural Development in all the states who we train. They then further train the extension training centers. We have 90 extension training centers across the country, and through them we reach the community. So I think Panchayati Raj functionaries play an extremely important role in this regard because they are the bridge between the community and government also. And they facilitate the community meetings. And there are all groups who are supposed to be part of these meetings, not just the SHG groups are part of these meetings. The marginalized sections from all sections of the population have to be part of these meetings. They have to take their consent, and then they go ahead with implementing the policies in their gram panchayats. So they are the major stakeholders. Along with them, SHG groups are there. Then there are other community structures like we have the farmers group, we have the youth groups, the women, the elderly groups, through whom also these initiatives can be taken forward for engaging the community in the school health education, for instance. Children can be introduced in the school health curriculum also, and where children they are told about these messages because they bring back these messages home as well. So that is one thing. Community mentors is something which somebody was mentioning in the morning today. So we, while in our aspirational blocks program, there was a lot of discussion on this. The community advocates, how they can work closely with the community, and there's a lot of acceptance because these are people from the community. So there's a lot of acceptance by the community, men, women, and everyone, as to what they have to say with regards to to promote certain health messages or to promote good health. So that's something which we can also look forward to, and that is what we are also trying to do. Those who are volunteering to work for us on this, we are training them as well through the representatives who are already trained by us, and they take it forward to the community.
Thank you. Now I request Dr. K.C. Sargi to throw some light on the community engagement practice in education institutes.
Am I audible through mic? So thank you, Dr. Kaul, for making me part of this conversation. And very good evening to everyone. The advantage of being last speaker is I could accumulate so many thoughts and I can just summarize. Since morning I've been listening to so many healthcare professionals and veterinary doctors. So I'm a management professor specializing in finance. For the first decade of my finance courses, I've been, of course, we closely work with corporates, and I've been championing this idea of wealth maximization, that is, enhancing economic value. And then these millennium goals and sustainable development goals concept has come up, and slowly corporates started moving from creating economic value to creating social value and then ecological value. And at IMD Hyderabad, Hyderabad, we have Center for Sustainability and CSR. That's where we try to champion the idea of creating social value and ecological value along with the economic value. We call this as triple bottom line or PPP, not public-private partnership, but people, profit, people, and planet. So I'll share two initiatives, one at our own institute and one which we have been championing with the HR fraternity and corporates. So my campus, like this IIPH campus, was started way back in 2011. It was a greenfield campus, literally in the middle of a village, where we displaced, I think, so many species of animals, including snakes and so on. And 800 of us are staying there. It's a fully residential campus representing from 25 different states. And since 2011, very consciously, we took a call that if we are championing sustainability, we should first practice and then advocate or create awareness to the stakeholders. So in our campus, it's a 30-acre campus, 90% is green carpet, having more than 10,000 plus plants and trees. And student community around 720 and 80 faculty and staff. The residents who the hosteliers usually come and share with us, there are so many snakes in campus. Then we say it is we who occupied their space and we need to learn how to coexist. And there are so many, all kinds of species are there, especially dogs. I don't know whether you have experienced dogs in campuses is a huge menace, but how we came out, there are some faculty and students who have adopted those dogs, and so we started coexisting. So first, last 13 years, we have been practicing or learned how to coexist along with plants and the flora and fauna in the campus and the people around. And that's how the Center for Sustainability and CSR, we have a goal of being net zero by 2035. And being net zero means we will have to have sustainable practices and coexisting with the plants around and animals around is one such practice which I would like to share. And second one, since morning I have been listening to all the speakers talking about, I met so many physicians, physical health. I don't know whether there is an acronym called VUCA, volatile, uncertain, complex, and ambiguous world. From VUCA world, we are moving to BANI world. What is BANI? Brittle, ambiguous, non-linear, incomprehensible. The difference between these two is the leadership strategies for or leading in a BANI world requires swift adaptability, whereas leading in VUCA world requires adaptability. Leading in BANI world requires somebody to be resilient and psychologically having psychological well-being. So that's where we engage with two communities, one HR professionals, the other one CFOs, finance professionals. We did focus group discussions with 80 HR leaders in 5 different cities, trying to understand, especially this phenomena came post-COVID. During COVID, all corporates were compelled to do from work from home and related so many psychological issues. And the HR professionals were at the forefront taking care of their well-being and ignoring their personal well-being. So that's when who will take care of the caregiver? So we made a small study and found that the role what were the reasons for the well-being of the HR professionals. One factor which was influencing their well-being is role expectations that HR professionals can take stress. emotional burden, workload, lack of recognition that everyone takes HR professionals for granted. Your basic job is to take care of me. So, and then the study is ongoing. We'll come with a final report. And the second community with whom we engaged is CFOs. CFOs are the one who will take care of the financial health of the companies, and they were terribly ignoring their physical health and also emotional health. So, through CI CFO learning sessions, we have started engaging with doctors, oncologists, gastroenterologists, and cardiologists, and first create awareness. So, where our institute is playing role, the Center for Sustainability and CSR is creating awareness towards one, all three of us can coexist: plants, animals, and people, and then focusing on emotional. Thank you, Professor.
Thank you, Chair, sir, for this information. We also take up a lot of initiatives in the University of Hyderabad campus, 2,300 acres campus, the green campus. So in spite of that, how do we cope with the existing issues in terms of creating some kind of ecosystem? So we have committees, student committees and faculty committees to look after the waste management issues and also issues related to the health issues related to students. And health centers also doing a lot of work, health initiatives. So the University of Hyderabad, if you look at, we always try to encourage students to engage in the communities and to promote them to the different social activities and community outreach programs, and also we also involved in the social responsibility programs. Recently, I think our students went to the Grace Cancer from 10 Kerala. So we encourage more students to understand what is the environment, how people live, how to come together. That creates awareness and also create awareness for health, hygiene, that creates healthy society and as you said, resilient society. So it starts from micro level to macro level, and it creates from the group level, then it builds spread across. Now I have one question, sir, CSRD. So in this community engagement models, if you see, one of the initiatives. So what will be the funding agencies that will take care, because you require a lot of funding also to promote these programs, community engagement programs. So can you throw some light on this funding aspects?
Sure. Being a finance professional, I feel funding is the last aspect which we need to be bothered about whenever we are taking these kind of initiatives forward. We was talking about Grace Foundation Run. Even we were part of that Grace Foundation Run. Believe me, there are so many corporates, so many NGOs, so many government entities which are full of funds, but they are not getting enough proposals. So funding is the last thing we concern about. If only we have the right proposal and the right implementation plan. There are several foundations like GSR Foundation from UK. We have been and our own corporate foundations like be it Infosys Foundation or Signather Foundation. All these foundations are thanks to the 2% CSR funding requirement. There are so many foundations which are, I know for sure Infosys is under tremendous pressure to fund looking out for the projects. If only we have the right proposal to present. So that is my take, Professor.
Thank you, sir. I request one of the panelists, last but not least, how AI and machine learning, digital technologies are bringing awareness or creating some kind of sustainable societies for the community.
I'll pick up this question. We have a center called Center for Digital Transformation, and recently I met Professor Rentala from Center for Digital Public Health from this institute, and the power of AI is huge and it is all pervasive. Usually people try to float the words like AI, ML. So simply the kind of One Health initiatives, if they were to be implemented at pan-India level, you were giving the stats of 1.7 billion population, the data it generates will be huge and only can be handled by large computing capacities, which are of teraflop size. And if only we capture the existing data and train the model using the existing data, we can predict and design most relevant solutions, highly customized and relevant targeted solutions at village level, mandal level, or at household level. So, at the fag end of the day, I think I would share only this part. We can have one whole day talking about AI ML application.
Yeah, thank you for that. To just add on one more, I know, just 2 lines. AI has one application where you can send the messages in the localized languages. So Bashini is one of the portal developed by IIIT Hyderabad, and there is Sarvam AI, which is also working on multilingual language models. So AI will definitely help us to reach to the last mile at the grassroots level in the language that they can understand. So the silos is not just a dictionary word, but it will go down to the level in the language they can understand. So I really bet on AI doing that.
And that AI and ML also will facilitate that early detection of disease prevalence. So we have a geoinformatics, there are so many AI tools are available. These tools are going to find out where exactly which locality is going to prone to different kinds of disease. So that early detection can be possible and prevention can be achieved so that spread is less. Now, I think with this, I conclude the session. I don't want to stand in between the audience and the people who are hungry, moving for lunch. So, I would like to extend a heartfelt thanks to our panelists for the excellent deliberations. And also thanks to Dr. Anil Kaur for giving this opportunity. And also the active involvement. Of course, the questions from the audience, 1-2 questions, final 2 questions. Anybody wants to, before I conclude? If there are no questions, I will. Please. Okay, fine. So this particular panel discussion really highlighted the indispensable role that communities will play in important role in One Health initiatives, and also the insights shared by the panelists are really immense knowledge, and also having a lot of extensions, and also like changes, and also driving health, and also environmental concerns, and social outcomes, and social benefits, and all these things. Now let us be a part of this One Health initiatives to take it forward to the next level and contribute to the sustainable community engagement. Thank you, one and all.
To give the mementos. We are all at the stage.
Thank you for that last panel. Thank you to the chair as well as to the panelists for contributing actively. And that brings us almost to the end of the program today. But before that, I would like to welcome a special guest. And the special guest is Sri Anil Soniji. Ajay Soniji, who is IAS retired, who has come here after a long journey and who has come straight to our institute without lunch. So we really appreciate your commitment to this event, sir. And thank you so much for coming. I will do a brief introduction and sir can speak briefly after that. Commencing his career in government in 1984 as an officer of the Indian Administrative Service, Mr. Ajay Prakash Swani has promoted participative governance, steered population-scale adult literacy and digital literacy efforts, and led the institutional design and setting up of the International Institute of Information Technology in Hyderabad, India. Mr. Sawhney served also as the Union Secretary for the Ministry of Electronics and IT from June 2017 to February 2022, where he brought tremendous focus to national public digital platforms like the UPI, Government e-Marketplace, the GEM, Umang, DigiLocker, Arogya Setu, and CoWIN, as well as the National Digital Health Mission, now being implemented as the Ayushman Bharat Digital Mission. As Principal Secretary, Health, Medical and Family Welfare, Government of AP, he concentrated on strengthening governance and delivering effective healthcare services and achieved convergence of service delivery with ICT, self-help groups, etc., with a focus on the full range of services and behavioral change that would yield the desired health outcomes. After his superannuation from the government, Sir is an independent director on the board of IDBI Bank and is also on the board of Data Security Council of India. Again, we are honored to have you, sir, here for a brief talk. Thank you.
Professor Kaul and other dignitaries. For me, this is sort of was a bit of an unexpected engagement. I was traveling, I was in the train from Vijayawada to Hyderabad when I got a call, got to know about this session here. And I have always been fascinated by what PHFI and IIPH have been doing. And long back, 2012 to 14, I was Principal Secretary Health in Government of Andhra Pradesh, the then unified Andhra Pradesh. So I've seen this institute grow to various levels. And today is I'm quite delighted to see that so many institutions have come together. Hyderabad is, to my mind, an amazing hub of institutions. Institutions of all kinds are present here. So what Dr. Sushmita Sundar mentioned about the work that could be done at the time of COVID, just shows what kind of capacities are there. I was involved in the design and setting up of IIIT Hyderabad. The chairperson for the governing council was Professor Raj Reddy. In fact, 25 years of his chairpersonship brought us to a wonderful level. And I remember that almost at the turn of the century, around 2001, 2002, I remember he's the only Turing Award winner, only Indian person of Indian origin who's won the Turing Award, which is like Nobel Prize for Computer Science. He's at the Carnegie Mellon University and credited with a tremendous amount of work there. We were fortunate in having him as the chairperson of our governing council right from 1998, end of 98. In 2002, when our first batch was graduating out of IIIT Hyderabad, we had a brainstorming kind of a session as to where do we go from here. It's a fledgling new institution. And he shared a very important insight. He said the most important advances, if we have to compete at a global kind of a level, the most important advances will not come in any single domain. A huge amount of work has been done in physics, in chemistry, in mathematics, in life sciences. It is the combination. It is when you bring a number of domains together and understand what is it that the other, what is their viewpoint. Share your viewpoint, spend time together, bring people together in various interdisciplinary programs. It is at the intersection of those that real innovation will happen. In fact, he mentioned under his guidance, we went to CCMB and to CTFD and a number of other institutions, IICT, to explore from IIIT Hyderabad as to what all we could do with those institutions. What could we do with pharma? What could we do with various institutions in life sciences? I think today's event, today's discussions remind me of that. It's a really well-endowed landscape in Hyderabad, where we have some of the finest institutions in computer science, in general, the University of Hyderabad, Osmania University, JNTU, a number of universities, some of the best business, the management education institutions, rural development, banking, insurance, a lot of institutions in life sciences, pharma, and almost in everything at one stage we tried to attract institutions. One such wave had happened in 1960s and 70s, and then another wave happened at the late 90s and early 2000, 2005. When many of these institutions came up, it's time to bring them. And the concept of One Health, I think from the time of the COVID, it's shown us that it's very important to zoom out. For many things, to get results, you have to zoom in. You have to go deeper. You have to go into the nitty-gritty. And only then you will get results. But for many things, it's equally important to zoom out and see all of this together. So I think what has started today, I hope that this will be an annual kind of event, and we will bring the strength of such wonderful institutions which are in Hyderabad, actually across India, and maybe from outside as well, together to see, to explore what all we can do together. Very happy that I, accepted this invitation and heard some of these very fascinating discussions. I wish IIPH and the organizers all the very best. We also hope that this will become a recurring kind of event. Thank you.
Thank you, Soni sir. What we'll do now is just two more things left, two little points. One is, of course, to thank everyone who is here, and the last one is to request Professor Paul for giving some more mementos to our speakers in a bit. Okay, so that brings us to the end of this event, which started out in the morning, and we had several discussions, very, very useful points that were made, and some discussions which were very passionate. The speakers were very articulate, and we had lots of points coming through, very, very useful. I would like to start by saying that when we were discussing about the objectives of this particular symposium, and Dr. Paul was talking about it, then the thing to think about is, okay, what are the objectives of this symposium like this? Is it to bring about a white paper, or is it to bring about a set of guidelines of how intersectoral collaboration will happen? The grand, the big targets. But then Professor Paul, with all his wisdom, he said, all that will happen, but let's just start with a conversation. And that is what has brought all of us here, to have a conversation, but it's not just one conversation, to have repeated conversations and to have plenty of opportunities for us to meet. Because this road, as somebody was mentioning today, it's almost like the One Health Street, the One Health Road, because it has so many institutes of national importance right here, which are working in all the things that we talked about today. So I would like to, on behalf of our director, Professor Paul, I would like to thank everyone, each and every one of you who has come here, and also on behalf of the Cyrus Poonawalla Center of Excellence, Center for Infectious Diseases, that is based in IIPH Hyderabad. A big thanks to the entire team at IIPH who's brought together all of us, who's put everything together and has helped in the smooth flow of today's event. But as we know, today's event started with some very special guests. Shri Narendra ji, DG NIRD, had come and he had given a very excellent presentation. We also were expecting Colonel Sir, Commissioner Health and Family Welfare, who unfortunately could not come because of a medical emergency in the family, but he has sent Sumitra Madam for representing the government, the state government from the health side. So thank you for coming, ma'am. All the chairs and the panelists, we say a big thank you to you for being so passionate and discussing various points and bringing out the best. The chairs brought out a lot of points from the panelists. So a big thank you to all the chairs who are here and all the panelists who have come and shared their points. And we would also like to thank the faculty from OSU who have come all the way and who have spent the entire day with us and have given their insights to enrich this particular event. So thank you very much. So I will not thanks to everyone. I might have missed out some, but overall, I would like to say that this event went on very well, thanks to the cooperation and participation of everyone here. And it couldn't have happened without a teamwork, which is the essence of One Health. I would like to thank the students who are here and who were here the whole day. Students both from IIPH as well as from the other institutes, the faculty of IIPH, and of course, the staff of IIPH, which I talk about as an entire team effort. So thank you again, and please, I will invite the Professor Paul as well as the dignitaries for the mementos, please. Professor Nandakishore. Professor Akhilesh. Shri Ajay Sani, sir. And all the faculty from IIPH Hyderabad, please. Can I request you to be here?
Dr. Shailaja.
I had a nagging feeling that I forgot something, and I did. One is the memento that Seth wanted to give from OSU to Professor Anil Paul. And the other thing is there is a group right here. So please join us for a group photograph here, right here, followed by high tea in the room next door. So please join us for a group photograph and for tea afterwards. Thank you.
लेके पीछे कैमरा कैमरे के साथ चल क्लोज करो उसको सेंटर से क्लोज करो Acha. Yes, yes, here. Once again. Thank you. All of you.
लास्ट ग्रुप फोटो कौन से डाल देता है दे दो लपड़ा को खाली नहीं नहीं इधर आ जाइए ऐसा आ जाइए बड़ा बड़ा हो जाता है अच्छा जल्दी आप हमारा सामान